Okay, members, declare the meeting formally open. Can I remind members about the protocols regarding mobile phones and electronic devices? So if you could switch those off, please. First of all, we have apologies. I have an apology from Jerry Carroll. Any other apologies?
Robbie Butler, due to unforeseen circumstances, had to go home. So.
No problem, that's great, thank you, Joanne. Item number 2 then is the draft minutes of the meeting of Thursday the 23rd of June. May I refer members to the draft minutes on page 5 to 7 of the meeting pack. Are members content with the minutes?
Yes.
Yep, okay, agreed, thank you. Item number 3, Chairperson's business. May I inform members that it is normal practice for committees to delegate authority to the Chairperson and Deputy Chairperson during periods of recess to submit views on the releasing or withholding of information in any non-routine contentious FOI request received. In the previous mandate, at the final meeting of each session, the committee agreed to this delegation of authority, and that the committee would be advised of any such requests, the views expressed by the Chairperson and our Deputy Chairperson, and the response issued by the FOI unit at the first available meeting following recess period. Are members content that we use this practice?
Yep.
Great. Okay, thank you. Okay, we'll move on to item number 4, which is the overview briefing on health and social care by RAISE. May I advise members that Dr Janice Thompson from RAISE is here today to brief the committee on the background to the issues highlighted in the legacy report from the previous mandate. I refer members to the RAISE research papers on transforming care at pages 10 to 45 and caring for an ageing population at pages 65 to 87 of the meeting pack, and a copy of the legacy report from the previous mandate is at page 46 to 64. So, very welcome, Janice. How are you? Good to have you.
Thank you. Yeah.
First of many again that we'll see during this mandate. So, I hand over to you.
Okay, thank you, Chair. Thank you, Committee. Yes, I welcome the opportunity to present to this new committee formally for the first time, and on a subject that's likely to take up a fair bit of the committee's time, I would imagine, namely the ongoing reform of health and social care. My briefing paper aims to provide the committee with a history of the direction of reform over the past decade or so. It also covers key areas from the 2011-16 legacy report, as the Chair mentioned, including its scrutiny, the committee's scrutiny of TYC, particularly regarding workforce planning and care for older people. Now, I do appreciate this will be old ground for some of you, so I hope you will bear with me. The paper is detailed, and I certainly don't intend to go through all of it today with you, but I hope you will find it useful as a reference tool for you over the coming months as you make your decisions on your work plan. In many countries, including Northern Ireland, governments are striving, as you know, to transform health and social care in the context of many factors, such as quality of care, driving up quality of care, increasing demands placed on services by ageing populations, increased numbers of people living with co- and multimorbidities, constrained resources, improved technological advances, and rising patient expectations. So in Northern Ireland, over the last decade at least, policy direction is aimed to shift care, as you know, from hospitals closer to home in the communities. Now, I'm not saying that reform started just a decade ago, because of course it predates that. For example, the Hayes Report of 2001 highlighted that health and social services should be more closely integrated to provide a seamless system. Now, that's an aim that mirrors many in later reports, so it has a long history. In 2005, the Department published Caring for People Beyond Tomorrow. That was a 20-year strategic framework for primary care, and it already recognised the need for wider development of community-based alternatives to hospital admission. A key focus was integrated working, and we're going to hear a lot about that in this presentation, and the introduction of primary care partnerships, with a new role for GPs in those, and they were voluntary alliances of health and care professionals working together with the voluntary and community sector. Now, despite positive local improvements in integrated care by the PCPs, the reform agenda did appear to lose some momentum in the years following, but it gathered pace again in June 2011 when the then Minister Edwin Poots announced a review that became known as Transforming Your Care. Now, TYC focused on changes that would make the greatest difference in outcomes for patients. Again, integrated care was in the spotlight, with a new integrated model of health and social care combined with population-based planning of services. The key drivers for TYC included, again, care to be provided as close to home as practical and possible, a shift of resource from hospitals to enable investment in more community services, and a changing role again for general practice, working in what are now known as integrated care partnerships, and they built on the previous primary care partnerships. Now, the ICPs, the Integrated Care Partnerships, have focused on improving how services are organised for frail older people and those with specific long-term conditions, and they're aiming to prevent hospital admissions. I've covered a couple of examples of those in the paper. Essentially, the services of ICPs are examples of integration in action on the ground. The TYC service model for primary care is a hub-and-spoke approach, with the hubs providing services which are too specialised to be provided in a local GP surgery. And this direction of travel also predates TYC, as the framework for primary care had already described such hubs. And for example, the Arches Health and Social Care Centre was completed in 2005, and the Grove Centre opened in 2008, and there are other examples in the paper. Now, two key messages that emerged from the consultation for TYC were that sufficient investment would be needed to make change happen, and alternatives needed to be in place before change occurred. And support for staff, who really are the key enabler to implementation of reform. There is no doubt that the reform process to date has been hampered by a lack of investment and the financial situation of recent years. The Department has had to rely on monitoring round monies to fund aspects of reform. And as the bids were not always successful, the implementation of TYC has not been at the pace originally envisaged. In January 2016, the Assembly's Public Accounts Committee noted that a key challenge for reform was to put the trusts on a more stable financial footing and a more sustainable financial footing, as they have no authority to move money from one year to the next. That is impeding their ability for long-term planning. Now, a main focus of scrutiny for the previous committee was to make every effort to track the impact of reform on the ground for frontline services and for staff. Now, given the scale of reform, this was an immense task. So, in its 2015 Workforce Planning Review, the previous committee engaged with stakeholders regarding the overall progress of reform, as well as the specific impact on staff. A number of key issues emerged for them, including the financial constraints that I've already mentioned. With regard to staff and regional workforce planning, the committee was concerned that this key area was underdeveloped, and a long time had been taken to produce a regional workforce plan. The committee recommended a wider approach to workforce planning to avoid silo-based approaches, and that the department should reconsider how primary care services can be reconfigured to deal with the ever-increasing demand for GP appointments. The status of TYC itself was queried. Later in the mandate, the department appeared to alter how it viewed TYC and referred to it as an ethos driving its commissioning decisions rather than a specific plan to be implemented. The previous committee were somewhat concerned at this approach in terms of the ability to resource or monitor the success of reform without a costed, measurable plan. The committee understood that the shift left of services also encompassed supported living options for older people as an alternative to residential care. And it was in this context that they carried out their review into supported living options in 2014. The committee's recommendations included that the relevant departments still needed to work better together in terms of developing housing options for older people, which would have the best health outcomes for those people. In 2014, the focus of reform moved slightly wider to encompass governance also, when Professor Sir Liam Donaldson advised on governance arrangements across health and social care in his report, The Right Time, the Right Place. His report contained 10 recommendations, and I've gone through them in my paper. And he recognised that TYC did contain good ideas for developing alternatives to hospital care. But he called for action, not words, and a new costed and timetabled implementation plan. He also called for an impartial international expert panel to review the configuration of services, whose recommendations would be binding on government in Northern Ireland. Now, this latter request was naturally very controversial at the time. In 2016, the then Health Minister Simon Hamilton stepped up the pace of reform again, and he appointed an clinically led expert panel based somewhat on the Donaldson recommendation, but it's a mix of local, national and international expertise, working with a collaborative and local approach too. The panel aims to consider and lead debate on the best configuration of services, and it's due to report within a matter of weeks to the new Health Minister, Michelle O'Neill. As regards finance, in March, Simon Hamilton announced the creation of a ring-fenced £30 million transformation fund in order to realise the vision set out in TYC. Since becoming Health Minister in May, Michelle O'Neill has stated she intends to refocus her efforts to reshape the HSC, with the report of the expert panel leading the debate. Really, to summarise what I've just said, at the heart of reform is the drive to build on the already integrated health and social care system in Northern Ireland, with frontline integration on the ground, via local population-based service plans and the central role for GPs in the integrated care partnerships, of which there are 17 across Northern Ireland. It has become clear that new models of service delivery alone are not enough to change day-to-day clinical practice on the ground. It requires processes and resources, financial and skilled staff, to help local managers and health professionals to change practice on the ground. With a suitable mix of both bottom-up or clinically led interventions to engage the clinical and nursing leadership, and top-down interventions that need to be standardised across the entire health system. The Donaldson report was clear that the broad direction of travel was right, but that implementation was lacking and basically needed to be got on with. The future of reform is, of course, now centre stage again through the clinically led expert panel. Now, on Tuesday of this week, myself and the clerk attended the Northern Ireland Confederation of Health and Social Care Conference. So I thought it might be useful just to finish with a few points from some of the speakers, particularly relevant to the reform agenda. Excuse me. The expert panel highlighted that they wanted to lead the reform debate, not write it or be the debate. It was to be clinically led, and they felt that after the recent summit with political parties, the working principles did have political backing. A key principle for the panel is the main value of the HSC is its people, not its buildings, but that further review of the workforce was still needed to support new care models. The panel were confident, or are confident, should I say, that Northern Ireland does have the capability in its integrated workforce to deliver on reform. But it recognises that Northern Ireland is facing an 8 to 10 year process building on the work of TYC. Jeff Huggins, the Director of Health and Social Care Integration in Scotland, spoke, and he highlighted their strong clinical leadership in Scotland, the need to integrate care around individuals and true operational integration of services. Now, the previous committee had already engaged with Scotland as a good practice example, particularly with regard to workforce planning. Allied health professionals presented a case study in a parallel session, highlighting how much more they felt they still could offer the reform process in terms of improving patient outcomes and saving money for the HSC. Heather Monteverde, Chair of the Long-Term Conditions Alliance, highlighted the impact of patients with long-term conditions on terms of bed days, and noted that self-management as far as possible and services close to home were the way forward. Laura Collins, a carer and a member of an ICP, highlighted that it was felt that HSC still needed to partner better with patients and communities to pursue citizen-driven healthcare and encourage people to take responsibility for their own health, though she noted that the social determinants of health must also be factored in. So to conclude today, this new Health Committee finds itself joining the journey of reform at a particular juncture, as the expert panel prepares to report to the new Minister. As you've seen, the journey has a long history and it's likely another 8 to 10 years to go. I hope that the detail in the paper and this presentation has given you a handle on what's gone before, what is currently happening and the challenges that remain, really in order to allow you to focus on how you wish to input to the process going forward. So I'm happy now to discuss any of the issues further or take some questions. Thank you.
Thank you, Janice. As always, a very detailed paper and a detailed presentation. I know from the last mandate how invaluable your services were for this committee. So I look forward to the coming months and years ahead when we will certainly require your help again. I just want to, first of all, before I bring in members, ask have we any data or any information about how we compare to the rest of the UK or Republic of Ireland, or even nationally, in the running of our health service and the situation that we're in now?
That's a very big question. Are you talking about in terms of the reform process generally at the conference, or are you just
in general? We know that, and we know from the previous mandate that we've had many papers that have indicated that we needed reform, and that we have made some steps in reforming that. And we know about our waiting lists, about our GP crisis, about general workforce planning. It's just how do we compare with other jurisdictions?
Well, in terms of, for example, commissioning arrangements and things in England are quite different from here, so I maybe not make any direct comparisons in that term. I mean, the Health and Social Care Board here is obviously under scrutiny in terms of the commissioning process here, so that is something obviously that will be looked at going forward. Our waiting times naturally are still are the worst in the UK, and Scotland has shown itself certainly to be leading the way very much in terms of tackling waiting times, and in terms of reform and workforce planning generally. I know the committee found it very valuable talking to Scotland workforce planning team. What I did find actually from the conference on Tuesday was the fact that the expert panel have clearly identified that a lot more workforce planning still needs to be done, and that is perhaps a point to think about, given that there's been already, I think, at least 4 years of workforce planning has gone on here before a review or a framework was published. So I'd say we're still seem to have a long way to go in those terms. Certainly when the committee was talking to stakeholders, one of the key issues that came through in the workforce planning review was that there did seem to be a lack of communication about what was actually happening on the ground. So a lot of stakeholders weren't actually aware of some of the TYC implementation on the ground. For example, I mean, the ICPs are doing a lot of good work in localities and in communities, and you know, that's maybe something that's something the committee could consider, that actual communication, you know, of what's going on. I mean, the term integration, I mean, we have an integrated health and social care system, which essentially is the envy of many other parts of the United Kingdom. But there's integration at different levels, you know. There's health and social care integration at the macro level in terms of, you know, the pot of resources and the policies and things. But what Scotland seemed to be very much focusing on was much more the micro integration and the operational integration on the ground. And that is where our ICPs are also coming in.
Okay, so we've got a lot of work to do then.
Yeah. But there is a lot of good stuff going on too, and I think a lot of that was certainly, as I say, came out from the stakeholders that, you know, perhaps just weren't aware of some of it either.
It's good to know actually that you know, the work of the ICPs, and that is, you know, starting to make a difference in our frail elderly and those with long-term conditions, because that plays into Donaldson as well, and very much what he, you know, that his vision was. And I suppose we look forward to the Bangor report to see what direction, and that will very much shape the direction that we go here within committee as well. Paula, did you want to?
Okay, thank you, and thank you, Janice. Just two lines of questioning. You talked about the £30 million for the Transformation Fund.
Yeah.
There isn't any detail on that, and maybe you don't have it, but I just wondered, you know, has that been plotted out now? Is that going to be departmental allocation? Is it Health and Social Care Board given to the trust?
There is a bit more information
Okay.
in the book.
I did a quick
I can find it.
find there. I don't
Yeah.
think in the report you've given us.
Yeah,
there's
I
any
mean, there
more.
certainly are projects that some of that money has already been allocated to. It's certainly something I can look into in more detail. I'm trying to see.
It would just be useful to see
Yeah.
where the investment is going, and even the time frame. Like, is that in this financial year, the 30 million, or is it non-recurrent? You know, it's.
I think it is a one-off pot of ring-fence money to be spent on, and other projects are specifically to be focused around innovation and reform. So it is very much for very specific projects that are going to take the reform agenda forward.
Okay.
So that's probably the best answer I can give to that
Okay, but
question.
if we could get more information, that would be useful. And then the second one is, I think you touched on it at the end there, around the conference for the last couple of days, around, for example, the lobbying from the allied health professionals. And I'm wondering how are they feeding into the reform process, and how much influence do they have, and in terms of departmental officials listening or the expert panel. I'm just conscious that
Yeah.
there's so many of them and they're doing such great work, but some of them are representing very small numbers, and it's how do they get their voice heard and their.
Yeah. I certainly think I got the feeling that they would love to come and tell you for themselves, so I'm not really sure I'm best placed to answer that question. But I'm just commenting on the case study that they presented, that they were indicating that they felt they had did have a lot more to offer on the ground in terms of taking the pressure off GPs and
I
doctors.
think we saw that through the physiotherapy and the referral to physiotherapy.
Self-referral, yeah. I mean, there are good pockets of work happening in different areas, like self-referral for physio. So I think they're probably best placed to put their case, but certainly they felt they had a lot more, I think, to offer. Yeah.
So I know that I know that they put forward a good case. It's really about how is that information collated and how is it fed? How does it feed into the reform agenda and the consideration?
Yeah, I'm really couldn't
One
answer
person?
that question. I think that will be one for how, perhaps the department or the panel, whenever you engage with them, how they have engaged.
From what I've been
With
led to
the
believe,
broader-
that they have met with AHP representatives. Of course, social work doesn't fall under AHP, so I know that was a problem as well, because not everybody falls under AHPs.
Yeah.
But from what I've been led to believe, they were met with, but we'll find that out as we go through the detail.
Okay, thank you. Thank
We
you.
will. Okay, members, no one else want to ask Janice any burning questions, Barry?
Just a quick one. I mean, in terms of TYC, there were 99 recommendations in total. Can you give? I would like to have an idea of how many of those are green lights or amber or red, where there is, and is there an accountability mechanism that is ongoing in the background in regard to it?
The previous committee engaged an external expert to look at the benefits realisation framework that the department had put in place to measure the outcomes from TYC and the benefits realised from TYC. And I don't want to put words in the previous committee's mouth, but I think at the time it was felt that the benefits realisation framework had come a bit late to the party, in terms of actual numbers of the 99 recommendations. That's probably a question for the department if they're still monitoring, a lot of those. But certainly the framework that they were meant to be using to look at it was a benefits realisation framework. That's something that's come from a business background, but a lot of healthcare systems have used it to monitor both benefits and what are called disbenefits.
And the other question I have is in regard to, obviously Bengoa will be coming out in the next number of weeks, and in terms of TYC, all parties I think welcomed it. Everybody has sort of a different interpretation of it, so what risk is there that everybody agrees with Bengoa but go in completely different directions because it's not specific enough perhaps?
Actually, that was a point that was brought up at the conference on Tuesday, that the working principles are not very definitive, but that was presented as an advantage because there's still, a lot of work ongoing, and they said they're still engaging, right up to the last minute. Again, $6 million question, isn't it? Everyone, yes, had agreed and still buys into the overall direction of travel that TUIC was in. The key, as Donaldson highlighted, as even the expert panel have highlighted so far, their focus is purely on implementation. They don't want to reinvent the wheel. They actually mentioned at the conference they weren't out to produce TYC, the revenge. It's very much focused. Their work has been very much focused on implementing it and getting, action on the ground, and that there's nothing wrong with the direction of travel.
Okay, members. Everybody else happy enough? Okay, Janice. Thank you very much, and we look forward to seeing you in the not too distant future. Okay. Members, we'll move on then to item number 5 on our agenda, and can I advise members that the Chief Executive of the Public Health Agency is here today to brief the committee on the work of the PHA, including current work streams and priorities. Can I refer members to a copy of the Chief Executive's presentation at pages 68 to 110 of the meeting pack, and advise members that a copy of the Director of Public Health's annual report is included at pages 111 to 148 for your information. So welcome, Dr. Eddie Rooney. Eddie, how are you? Good to have you here with us.
Thank you.
And if I can hand over to you.
Thank you very much. Thank you very much for the invitation to come along. I'm going to be giving a very high-level overview of the work of the Public Health Agency, but very happy, obviously, to drill down in the questions. And I'm going to speak very, very fast. Just by way of a little background, we're now up and running just over 7 years in existence, and originally formed from 10 functions really brought together into a regional body, and probably with what I certainly think is probably the most wide-ranging legislation for any arm's-length body. Fundamental to that is to protect and improve health and social well-being and reduce health inequalities for everybody. The rest of the legislation spends a lot of time telling us how we've got to work, and fundamental to that is we've got to work with others. That means us actively helping others, as well as collaborating with them, but also helping them to help us in terms of improving health and well-being. We're in a system that, you're probably aware, was deliberately interlocked to be interdependent. So I don't have HR functions or finance functions. I get them from the other bodies, but I provide the professional advice for the whole of the health and social care system. And we do that with a bit of legislative clout as well, because, for example, in commissioning, not only do we advise, but there's a legislative requirement for others to pay due regard to the advice that we give. And at the end, we've also got an approval rule in the commissioning plan. But around that is just fundamental to the whole of the system is joint working. We work jointly with all the other health and social care bodies, and as you'll hear, far beyond that as well. I've given a little bit of slides, and they're hard to maybe follow, but I've given a couple setting out our key functions, and I could spend a day on this, but I have a funny feeling I'm not going to be allowed to do that. But just to highlight a few of them, I mean, the most common area for you is going to be health improvement. That's what you tend to see most within your localities. We fund just about 600 voluntary and community sector organisations, and underneath them and through them, work is done in absolutely every corner of the country. Key themes of that work tend to be around empowering healthy living in local communities, and that includes areas such as smoking cessation, obesity, alcohol, drugs, mental health, sexual health. And I'll come back maybe to that just at the very end, a little bit about that. Another area which we tend to hear about, usually when there's an emergency, is the health protection function, and that tends to be pandemic or the snow, when that hits the headlines. But the surveillance that goes on in terms of infection control is going on all of the time. Just for example, 2015, our staff were involved in leading 164 outbreaks. So there's be 3 a week are happening, and you will pick those up in your localities, because sometimes it'll be a school, sometimes it'll be within a hall or something, and that is really going on at time. It's also the area that really is closest for us to be a frontline service. It's very different from some of the other work that we do. That area also covers immunisations, where typically we've got the highest rates in the UK. got there, I mentioned screening. I'm not going into this, but we've got 8 active screening areas going on at the moment. And just in the next bit down, I've said a little bit about quality and safety, because quality and safety is a huge area now. That's a strategic area where the department is really drawn in lots of disparate activities and absolutely central in terms of keeping our services safe, but also reaching out beyond that. I've also highlighted that direct interface with the public, which is an increasingly important part of what we do. And again, the range goes from the patient experience, such as 10,000 voices, which you've heard of the past. And that's really where not only we're listening to what people say, but we're really trying to turn that into a rapid response into the system and shape the system. And we've had some great initiatives like Hello, My Name Is, coming from that in terms of listening to what patients actually wanted. But also at a wider level, really embedding that whole public and personal involvement right into the culture of the health and social care. And that's a critical stage of that at the moment, and good progress being made in that. And then the part, again, which people are probably most familiar with, the public information campaigns and the various ways that we interact with the public, social media, but also through our campaigns. And at the moment, we've had, obviously in the past, ones Organ Nation, others, John, you've been heavily involved in. But at the moment, we'll be running on smoking, obesity, sexual health, mental health, and planned campaigns coming on dementia, tackling stigma around that, and breastfeeding. And we try to keep that refreshed into key areas, and it's a key part of our overall activities, integrated to the other work. And then the general issues about how we really help the whole of the health and social care system. And a lot of that centres around the role of our professionals, because within our area we've got key professional blocks of key medics, nursing and allied health professionals, but also researchers in there, and how we work with R&D, health intelligence, and try to bring all of that professional support to the whole of the health and social care is a key element. And emerging areas as well, such as telemonitoring around e-health and innovation, which is again becoming an increasingly important area for the future. I've struggled to make sense of all of this because it's such a wide range, and I have put down a little ripple diagram, which is my brain trying to make sense of it. And at the heart of it, I mean, this is about prevention. That's our business. It's about prevention and early intervention. And at the heart of it, we've got those activities around keeping our services safe. And what we really want is, we want, when people need our services, to make sure that they use them for the least possible time and they're out living independently. Ideally, we'd like them not to be in there in the first place. But also that notion of keeping safe, rippling out into the community, and that's immunisation and screening, early diagnosis, really try to get people back as healthy and independent living as quickly as we can for their benefit. But it ripples out further into the community with all that healthy choices and healthy living and empowering local communities element of what we do. And yet again, our responsibility goes into what causes the issues. So dealing with the social determinants of health, the most important of which is poverty. And right through to giving people a voice, because part of our legislation says we've got to empower people to actually take control of their own health and well-being. And we're doing this simultaneously. Some of that is a response that happens in minutes. Others, it's a response that will take 2 generations. And it's that notion of such a variety, but also as we ripple out, we have less control. We depend on more partners, and that's a critical issue for us carrying forward to the future. If we want to have impact, we need to reach out to those people. I've given a little bit about the budget. I'm not going to dwell too much on this, but we've got an overall budget of just about 100 million. It represents just over 2% of the health and social care budget. And within those programmes, and I haven't given detail of them, I can provide that, but for example, the health improvement ones would be suicide prevention, a major area there, drugs and alcohol, smoking cessation, and that community infrastructure building. All those programmes around making life better that we carry out within communities tend to be the big areas of investment in there. Issue which we've always got asked in this, well, does it matter? Does it actually make a difference at the end of the day? And I've given a very busy little slide with lots of bubbles on it, which is our way of trying to make sense of this interconnected world. And at the centre of it are preventable deaths, and that's the tip of an iceberg, because under them a huge amount of preventable ill health that leads to that. And it's our way of trying to determine where you can put the effort to have the greatest impact. And the impact tends to be multiple. It's not just on a disease, it's also on the causes. So by targeting what we do, we can also tackle issues such as our health inequalities issues through the activities that we do. Does it work? Well, the big graphs say, yeah, it does. Life expectancy is continuing to rise. So the bottom line is, and if we add to that healthy years lived, for the population of a whole, the graph's going in the right direction, slowly, but it's going in the right direction. And when we look at specific areas like cardiovascular disease, you can see a halving of that over a 20-year period. And when we look at the factors that contribute to that, smoking cessation issues, we know that these things do have an impact. And even the obesity time bomb, which we've all talked about, and I've talked about in previous areas as well, the curve has been flattening out. And a lot of that is attributed to work which is going on at community level. It's not just from us, but it's the activity and conscious activity being undertaken at community level. But, and there's a but, I said our fundamental legislative responsibility is about tackling health inequalities. And you know what, the picture's not so good in that. If we look at the highest versus the least deprived areas, we've got, if you're in the highest area of deprivation, you're twice as likely to die from smoking, 3 times as likely to die from suicide, 4 times as likely to have heart or lung disease, 5 times as likely to die from alcohol or drugs. You'll die on average 7 years earlier if you're male, 4 years earlier if you're female. Remember, the travellers community, that's 15 years, and 11 years, and it's 2016. And this is times differences. This is not sort of marginal percentages. All of that information is what is fed into making life better. Is to try to take the whole intersectoral approach, and this is really what is driving and now reshaping how we deal with our own priorities. All our business planning is built around making life better. It's owned by all departments, but is also a critical template for us to work in. It deals and starts with that issue of the inequalities, and I know that you've seen the bus route one, which is down there, go up the Lisburn Road, and literally 100 yards, you start to add years of life and quality of life on that. Those themes that it is built around have taken issues around breaking the cycle to building the core capacity within communities and empowering them. But it also fits in very, very clearly into all the best international evidence that we can gather in terms of how you can actually turn a curve on issues as fundamental as poverty and inequality. I've got a lovely map of aligning, because I think this is why this is so important at this particular time, because where making life better has come from, and you can track it down. I've tracked it the 40-year story to get to what we've got at the moment. At the same time, others have come the same path. The local councils, in terms of their planning, are coming up. We've all come up with the same answer. We've got to do outcomes. We've got to build in that collective responsibility. It needs to be evidence-informed. It needs to have well-being right at the centre of it, no matter what direction we come out for. It needs collaboration. We need to tackle long-term determinants, but can't wait for those. We've got to do stuff right now, and we need to join our planning and our delivery right across the sectors, and that's what we've got the potential to do. We're working very closely with local government, and have been, and with community and voluntary sector as well. But Programme for Government gives exactly the same criteria using the same basis, and we've now got a basis for unifying our efforts in a way which, to be quite honest, I haven't seen in 30 years of working this. It doesn't mean the challenge is any less for us. I suppose finally, Chair, one of the issues with public health is that it's not sets of facts and figures, and I know from people who have met in your constituencies and other places around the table, it's a very personal issue for us and for our families, because it is describing life for all of us. And sometimes the complexity can be overwhelming. There's just too many bits, and we tend to back off from it and tend to go for the short-term issues. But I've seen how much has been done. I've seen from it's been West Belfast, I've seen in Lisburn, I've seen South Belfast, I've seen so many areas, I've seen in Foyle, just about everywhere around the country. in terms of the amount of activity that actually is going on. And one of our challenges is to really just to put more effort in bringing that into greater impact. And just leaving you with the last thing, as a message from Michael Marmot and the World Health Organization, and was, don't get overwhelmed by it, and we can't afford to in this. You know, do something, do more, do better. We've learned a lot in the past, and we've got a better chance, I believe, of actually doing something about it collectively now than we've ever had before.
Okay, thank you, Eddie. And as you'll know, I've always been a supporter of the PHA. I supported the work they've done, and we can see the difference that those years have made now, to where we are with diagnosis and screening and research and development. So I definitely commend the work that has been done there, and also as chair of the Sexual Health Committee and chair of the stroke and heart disease. You know, some of the campaigns that have been run over the years have made such a big difference in many people's lives and have saved lives as well. So I know the PHA has a massive role in many of those things. I attended an event last night to do with bowel cancer at the medical centre at Queen's University, and you know, the bowel cancer screening, and albeit we'd maybe like to see something a little bit different done, but the difference is that has made. And so definitely I would commend you for a lot of the work that has been done. I just want to maybe just start by asking you where you feel that the Public Health Agency sits with the transformation agenda. I agree with you. I think we've reached the stage where it's quite exciting, the time ahead, when we look at community planning with councils and the programme for government and the aspects of that. I think a lot of work has been done that has led us to where we are now, and I think we have an opportunity now to just grasp that. So it's just, where do you see the Public Health Agency sitting with that?
I think it's absolutely central to it. I mean, to be honest, I'm not a great organisation person. You know, the issue for me has always been, it's about public health. And you know, my first involvement in this was literally 30 years ago, at a time when, you know, everybody's saying, you know, what's the point, too long term? And we've now seen what can be done. And the issue for us has always been to make sure that public health was the actual building block in terms of as we move forward. And I have to say that certainly appears both in the previous administration and I expect moving forward that is going to be a key element of it, and that is welcome. I think it has to be that way. One way or another, there's only so much that we can do in terms of, from acute services on, if we do not deal with that fundamental issue of communities. And that's at both ends, in terms of the prevention of what comes into the system, but also on the other side of it, and making sure that we're somewhere safe for people to go to when they are in that situation of getting well again. So fundamentally, you know, the future of health, we know, I mean, we've talked about it as statistician in previous life when we were doing the demographic projections 30 years ago, so we've known about what's happening in demography for a very long time. But really it's now has come to that point where we must, it's an imperative, it's building on that community side. So I think the agency, certainly from the point of view of the reviews that have been carried out so far, you know, the functions that we do, I think, are critical. I think it's a very exciting time for health and social care generally, because I do think administrations need to fit and really support very actively the needs. And I don't think any of us should be sitting preciously saying, well, it has to be exactly this way. That relationship with community is going to be better as local government transforms. You know, is going to be a critical relationship with us for the future as well. And I think one of the keys to the success of actually getting all our planning from top to bottom in a way which will benefit communities. So I have to say, within the agency, we're really up for it, quite excited, but we know it's going to be challenged and challenge us in terms of how we do things, and it should.
Yeah, absolutely. I mean, I remember part of your presentation, you talk about the empowerment of people,
Yes.
and that's very much, I think, we as MLAs should be part of our ethos as well, is to empower people. And I think when we look at some of the statistics now that we have to do with early diagnosis and to do with screening, we've already started that process through your agency and others to bring that empowerment about. And I don't think that's something that we should drop the ball on either, because when it comes to health inequalities, that's most definitely the communities. We know the communities that we need to empower and need to encourage. And I know that, I know even from my own area, the amount of work the PHA had put into trying to empower those people to actually make a difference in their lives. And it has worked. it maybe hasn't gone as far as we'd like it to do.
Some way to go.
I think, yeah, but I think we're, again, as I said before, we're all too good in this country beating ourselves up. But I think there has been improvements. Haven't been maybe significant improvements, but there's been improvements on many levels, and a lot of it's thanks to your agency as well. Just also, you had mentioned about the 2.3% of the budget, which which is quite unbelievable at times to think that is the amount that you receive. Do you any idea how that compares to other jurisdictions and what they
we've
receive?
tried to do that, as you can imagine. Actually, very difficult, just because of the nature of the structures. Even comparing with England, because local government's role is very, very different there. The issue for me has been less about the 2.3% going to public health agencies, it's about the amount of investment that we make as a society in public health generally, and that includes all of the partners in there. But yes, I'd say, of course, it's far too low.
I wouldn't expect anything else from you. So, okay, I've got lots of members. One thing, I've got Joanne, then Di, Gary, Trevor, Catherine, and then Paula. So can I just remind members, if they try to keep their questions, no speeches please, but questions, and the same with you, Eddie. Okay, first Commissioner Joanne.
Okay.
Thanks, Chair. Can I thank you, Eddie, for your briefing, and again, the valuable work that the PHA does to promote public health. I'm a big supporter, as you know, as well, especially around organ donation, as you alluded to in your presentation. From my own perspective, I'd like to ask you about future promotion of organ donation. I'm a huge supporter of your Speak Up and Save a Life campaign, and we had the Miscellaneous Provisions Bill changed in March to include clauses from my own private member's bill, including a duty to promote. So can you update us on the plans to promote organ donation in the future, and when the changes were debated in the House in March? I praised the PHA, I'm sure you read the Hansard of that, and encouraged that the real organ donation heroes are the charities, and they must be included in future campaigns. I know I met you over 20 years ago supporting those charities, and you have been a great advocate and supporter of those valuable charities. So how will you ensure that their voice and expertise is heard?
And Chair, maybe if I declare an interest in this, I'm president of one of those charities, Transatlantic Sport NI. But look, I think we've made great progress in terms of organ donation and getting it into the public psyche. But as you know, Joanne, we have a long way to go in terms of translating that into what we really want, and that is to make organ donation an absolutely natural part of what everybody thinks, to the point where we don't have to preach about it, and with some way to go in that. I do think the legislative clauses will really help. And legislation itself does not answer the questions, but they do give us, I think, a real focus to build support around that. And we're waiting for the department in terms of setting up a clinical advisory group around that, which I think will be a very important step as well. Our issue is that we've had the charities doing this where they do it 365 days a year on a voluntary basis, and
They sleep and breathe it,
about
they
it.
do.
And we do know from the previous figures it makes a huge difference. Even from the old council days, you could see an organ donation registration ranged from, I think it was 11% at the lowest to nearly 50%. And the only thing we could put that down to was actually local families literally going around their areas and bringing this home to people. So I'm looking at this very favourably. We've had fantastic developments in the science. We've had great developments in the service and a real enthusiasm. And I think that whatever happens, that we've now will have the basis not only to deal with the public information, but also to make that promotion an absolute duty of everybody involved in this. And I think they're up for it.
Would you agree the charities need their voice
Charities
heard?
absolutely critical. We've involved charities within everything. Within the Northern Ireland Committee, we've involved them. Right, they've been critical players within that. And whatever it is, because that at the end of the day is what's got to carry. We can only do so much within the rooms. We've got to carry the message through, and it is what is happening at home. It's got probably a bigger impact than anything that we can do. And I've no doubt, we've seen a great rise.
Do you have a time scale, Eddie, for future?
Well, literally we're waiting to hear from the department now, but I would expect it to be very, very soon.
And the Chair touched on funding and the small amount of funding you get
Yes.
for the work that you do. Are you aware of any future further funding being made available to promote organ donation following the changes to the Miscellaneous Provisions Bill?
Well, it's a prioritisation for us. We know that funding will be attached to that. I haven't seen the amounts, but that's a welcome change, because up until now, the bulk of work that we've done has actually been by simply prioritising this issue within our existing budget. So I think everything will help on this. And also the potential now to link that into the broad support, which I would expect to be welcomed by charities as well, because I think, say, their efforts have been voluntary up to this point. And I think they
Unsung
could do
heroes.
every help. They are, absolutely.
Okay, thank you, Joanne. Dahi?
Thanks as well, Eddie. What's particularly useful, I think, is the graph on the potentially avoidable premature deaths.
Yeah.
It sort of encompasses the challenge ahead of us. In terms of your budget, 2.3% this year, you've been going for 7 years. How's that changed?
It's increased. I
Over the past
mean,
7
you know,
Where did you start from?
we started with about 65 million roughly at the start. So we are one of the parts of the system that has actually grown our budget. And an increase in that came with Programme for Government money, identifying public health at the last mandate as being a priority. And that allowed an increase of the money coming into us at that time. So we've never been complaining about that side of money. I think the issue for us has always been is about the level of investment of the whole system and whole government, because this is a whole government issue, to allow us with sufficient intensity as a community to turn some of these curves. And I do think the Programme for Government this time round will give us an opportunity to really identify how that can best be used.
Because I was going to ask as well, a lot of good programmes, the majority of them tend to be within the Department of Health. There's exceptions such as Connswater project and that. Do you believe the Programme for Government gives you an opportunity to operate more with other departments to deliver on objectives?
It does. Making Life Better has already given us that. I mean, Making Life Better, we sit in a joint grouping, and I sit in a joint grouping with an all officials group covering all officials from departments. The ministerial group itself met before the election, and again covering all party interests, and I think is a critical element at official level in particular about keeping that joint work going on. So I think the context is community planning comes in, because we're all sitting on the same people are really sitting on all the committees in community planning, is to make sure that we join those agendas together. And that's where I think we've got real potential, because I mean, we've seen things, we've done this particularly in, for example, in Belfast. We've had the Belfast Strategic Partnership as before community planning, in which I co-chair with the Chief Executive of the Council and the Chief Executive of Belfast Trust. And through that we've initiated a lot of joint working, where we literally joint plan, harness our resources together, and we build things. You know, we know it can work, and critical issue for us is to get that common agenda and to build around it. So say the issue has been less for me about getting truckloads of money coming in to one source. It's literally about us collectively putting more resource into where we think it honestly can make a difference.
And in terms of the savings, I mean, obviously there's a summary table there, quite usefully outlines the potential return on the investment. But is there anything concrete? I mean, I want to see further investment in terms of prevention. I see this very much as invest to save the PHA. But for the past 7 years, can you say in concrete figures, this is how much money we've saved the health service?
Yeah, we can certainly tell about the return of it. The Director of Public Health's report has really been very good in telling us how the investment works. But even within our own particular areas, we do track that investment quite tightly. You know, so for example, in R&D investment, we get pretty much a 4-to-1 return for every pound that we put in, levers in more activity around that. And then when we're looking at specific programmes, like Family Nurse Partnership, for example, you know, how that is designed and the evidence around it, of which 30 years of evidence around it, looks at that return in terms of societal return, not just in terms of health, but in terms of everything, pretty much every government area, in terms of the benefits of that investment. We use that evidence in each of our areas in terms of helping to design our programmes. That's why so much, I mean, everyone in the world, including Programme for Government, are saying, you know, we've got to break the cycle with early intervention and children and young people, whatever. And that ties in with pretty much everything else, with all the other evidence that we've got on that, and is the heart of Making Life Better. And we're getting better at that. I have to say the science of it is far from perfect. But we are getting better in terms of where we can not only target that and turn that into return. And it ties in very well with stuff that's been done by the University College London, their Health, which is where Michael Marmot and that WHO team are based, and they've looked at financial return right across all those issues of the life cycle as to where you invest to get the best return. And it's no different from what we're doing. Early years is the biggest return, and the relationship with that, and preparedness for education, and looking after older people.
And finally then, within the booklet, it refers to the 20 mile per hour policy that was debated ad nauseam in the last assembly. So it's pointing up a potential saving of some 261 million. So could you give us an idea of what evidence there is to indicate that saving will be realised, and in terms of policy making within the assembly, what are the priorities we should have for the next couple of years in terms of changing policy like the 20 mile an hour to realise more savings in terms of the public health? Right.
Well, the evidence of 20 mile an hour, I think it is a very good example, because to get that return depends on how you bring it in. And that is one of the things that the evidence has shown, that not, going around plonking big stands and lollipops telling you that you're going to do 20 mile an hour from now is not an effective way of actually making that change and getting that return. Doing it with communities does work. And that's one of the messages that has also come out about that. It's not just about the policy. It seldom is about just the legislation. It's about how it is actually implemented and the extent to which that is actually meeting community needs. And it's like Joanne's point in this. So where there's that ownership of it, not only does it give the potential to have successful initiatives, but it also gives the basis to ripple those out. And that rippling out has been a critical part of what we do in all our areas, and that includes a lot of our community investment. We're relying on communities to do the heavy lifting in that as well. So a lot of it is about how it does. Certainly the evidence shows brought in the correct way, it will make a difference, but it needs to be brought in the correct way. And that principle of doing things collectively with our community rather than on our community. And that's a big lesson for us, because it's very easy for us just to throw the messages out.
Okay, thank you, Gary.
Thanks, Chair, and can I welcome Eddie to the committee today. Just to touch on the one of your priorities was around health improvement and engaging local communities. And I'd just like to congratulate you on the work that you do, even yourself on the ground within my own constituency in Foyle. The statistics are still very worrying around the areas which are most deprived, and of course myself and Mark's constituency is right up there in terms of deprivation, unfortunately. In terms of, what is there an answer to trying to get these figures down? Is it solely down to finance, or are you seeing, we are aware of some very good projects on the ground. The difficulty they have is they can't get the funding to run those programmes. So maybe you could give a wee bit of your view on that.
Can it be done? It definitely can be done. And what we've really been gathering is the evidence right across all the interventions that we've been carrying out over the last number of years, and beyond the last 7 years. And if you look within any of our geographical areas, you can see yourself how some places have moved on quite a lot. And a lot of that has been about that harnessing of, it hasn't just been about throwing cash, far from it. It's been about how that has been brought in, is building that core capacity, particularly within our working class communities, to the point where there is that confidence to go on and something to build and something to spread around that. And we have seen that happening. I think we've got a very good basis for that. I think we've got a different issue which we also try to tackle, is that a lot of communities get left behind in that as well, and that can actually, while moving some areas forward, we can find that others get further left behind. And an issue for us is also in looking at those areas with a weaker capacity to make sure that they aren't left behind. But again, cash on its own is seldom the issue. It's about harnessing all the resources that are available. Local government are finding that as they go through the community planning process, and we're now getting the integration of those factors. Our big issue, and the lesson that we've all learned, is it's not just health. So if we go in just in a health agenda, for us, employability, education are every bit as important. And it's making us think as to that we've just not to put our energies into one track. We've also got to be working through others, helping them to help us, but also working with them to move that forward. one of the things we've missed in that is the infrastructure from central government down has been patchy on that. It's tended to be initiatives, often disconnected, and I've been part of these, so I'm guilty of this in the past. Our real challenge is joining up those now. I think we've learnt a lot. We've also learnt a lot about the barriers. And I do believe that those barriers, we've got a real chance of overcoming them, but I will never underestimate just how big a challenge that is. But it is about mobilising ourselves with communities to really do what we know does work with them and rethink ourselves about how we do that.
I think that's useful, and in terms of, you're right in terms of the silo mentality, and we've been hearing it quite significantly over the past number of weeks, and you're right in saying that it's owned by all departments, and we just heard this week that the Infrastructure Minister and the Health Minister have joined together around the active school travel programme, which is welcome. That's an example of where departments can work together. But in terms of the community planning element of it, there's a concern, and when I was in local government I started to see it happen, there's no consistency, if you want a better word, across the province in terms of, we see various areas, Londonderry and Strabane Council, for example, we're told is slightly ahead in terms of where they're at around community planning, whereas other areas, so how can you ensure that where there are areas where there's best models of good practice, programmes that are working, to ensure that those are rolled out or taken into other areas as well?
Well, I'd expect Derry, Londonderry and Strabane, of course, to be ahead on this here. I mean, you did the one plan. And Strabane did a lot of work as well in terms of that community, at a time before community planning was coming in. And I think that others have actually taken a lot of confidence in that, because I do think that it shows that if everybody can actually harness all of their energies together and start with maybe a different page and a blank page in this, in terms of how they contribute to what can work within communities, you can actually have a stronger engagement and ultimately a stronger outcome. And that was when it wasn't fashionable. I think now the whole system has moved towards that, so there's a much better chance of system support. We work with all 11 councils. All 11 chief executives have also met with the health sector chief executives to sit down and work this out, because we're trying to make sure that we don't just, that things don't, on issues around coterminosity and issues like that, we just don't lose this opportunity. And those sort of conversations have been absolutely vital. So we regard community planning as being a key objective for us to make it work, and that's how we're entering into it. And our issue is not just to bring our brains, we've also got to bring resource into it. But it's not about handing over resources, how we harness that together. We're thinking in different ways now, Gary, and really, I know it's going to be a wee bit of a fraught time, I think, for the next 12 months in particular for community planning to bed in. And everybody has started at a different starting point, but we have been around them all, and different paces, but they're getting there.
Okay, well, thanks, Eddie. That's good news to hear, and keep up the good work.
Okay, Trevor.
Thank you, Chair, and thank you, Eddie, for your presentation. In relation to, much has been made about the amount of funding you get, but in relation to the different areas you look at, if you look at the smoking cessation, can you give an indication of what you spend in each of those areas?
Yeah, I can give you a full picture of it if you want, Trevor, because it's quite a long list.
Well, there's probably two I'm interested in. I suppose the two headline ones for me would be, so I'm a non-smoker, but I'm obviously interested in the smoking prevalence and what you're spending to try and help reduce that. Yeah. And obviously, there's huge savings there in terms of, in your slides it talks about 19 odd million for every 1% you can reduce that. Yeah. So I'm interested in the 100 odd million, how much you spend towards that. Yeah. And then the other one is the strategy to reduce overweight and obesity, which I should declare an interest in, because I'm both.
Can't we all?
Speak for yourself.
Just in terms of those particular areas, in relation to smoking cessation programs, because the big issue in that has been nicotine replacement and making that available free everywhere. Overall, smoking cessation is around about 4 million in direct programs to that. Obesity has set programs sitting around probably about 1.5 to 2 million of direct programs. But those areas also run through pretty much everything else that we do. Because particularly in the likes of smoking, because we know that if we can get a reduction in that the benefits are not just in terms of health benefits, but it also is a key contributor in terms of those differences that we find in terms of social differences too.
So suppose, I mean, it's a leading question. When I look at your table then, whatever you're doing doesn't seem to be working in relation to the reduction, because you have two targets. Yeah. And the targets are probably higher than they were in the 1990s. Yeah. So is there more money to be spent there, or is the programmes wrong? Or well, I mean, what can you do to convince me to be neither obese or overweight, Eddie?
I think they're two different stories within the smoking cessation and the obesity in particular. I mean, the issue for the obesity has been a curve that was going that way. Historically, that's been the issue for us. The issue has been very much in terms of how to stop the rising level of obesity, and our issue is that in the long term that is still the case. I mean, we're very worried about childhood obesity. We're also worried about how do you deal with something that's driven by societal changes of which we have all been part of, sedentary population. And the ability for us to do that, for example, from an advertising programme on its own is not going to be powerful enough. This is one that really needs to get into the mindsets of culture, how we live, and go against a trend and trends in many ways. I think where we take comfort in this is that with the right targeting, for those of you who are doing the couch to 5K at the moment, or park runs, if you take a look out at a weekend in any of our parks, it's getting over the issue of having programmes simply going out, starting, stopping, into actually building on the momentum in our communities. It ties in with something which Gary had mentioned about active travel with DRD. People will not be able to engage in those activities if there's nowhere to do it, even though the potential might be sitting on their doorstep, but if they're disconnected from it. So we're doing a lot of work around, for example, the greenways, but with the communities. And in terms of initiatives that we've undertaken in that recently with, for example, Belfast Council, you will see the outdoor gyms coming up in some of our most deprived areas. But it's not to put bits of equipment there. We work with the community and the programmes around that. If these aren't being used, then it's not going to work. It's been a slow burn on it. It's a hard one for us. Personally, I can say that as well, because I've been part of that. You'll have to live these things out ourselves. But the issue for us is, and this is always a problem of prevention, is where would things go if we weren't intervening? And in this area, absolutely, I am convinced that we would be in a worse state. Are we there yet? Not by a long shot. Not by a long shot. But again, I believe, Trevor, those issues are coming together.
And I agree with everything you say in terms of societal change, in terms of how it is going that direction. However, I suppose what I'm trying to see from this, and I'm not seeing it in the graph, which I appreciate you're saying societal, saying it's going up, but you're probably keeping it at a level keel. It's considerably away from distance from your target, and it's obviously considerably far away from where we all want to be, even me as an individual. I mean, whilst I can jest about being overweight, I find it difficult. I don't know, maybe males are more difficult than females, but I find it certainly difficult to get into a programme to assist this. And I'm not talking about myself, but I'm trying to talk about society in general. So really, I'm trying to get some sort of encouragement from you that you are still looking for other ways to do this.
Well, absolutely. I mean, internationally, this is one of the hottest issues that we're dealing with as well. My first involvement wasn't in the health area in this year. I chaired the Childhood Obesity Task Group in 2007 from education at that time. And the issues we were looking at there, in the same set of issues, but I have to say we did research there with children as young as 2. And the extent of the problem wasn't just in our territory. It wasn't an issue of awareness. 2-year-olds were pretty aware. They could identify good and bad foods and good activity. The issue was parents and the lack of time that people spent and the lack of facilities around. And it didn't mean gyms, just it was literally some basis to encourage people to undertake that activity. That's where the biggest changes have been recently. And I do think we're going to be seeing the positive impact of that. But we've got to keep it in every front. We're heavily working on this in workplaces at the moment and getting a very good response in that, as well as local communities. But much of the facilities that we've got at the moment weren't in place 2 or 3 years ago. So I think that's our challenge. Can I say to you we're going to get down to a specific target at a time? It's going to be hard. But it's an area which we have to crack, and I do believe that we're on the right path for it, and I've certainly tuned into how to do it, and we're going to try.
Can I ask supplementary on that?
No, not next to it, it's just to be supplementary.
Yeah.
But to this one, though, it's on the obesity and the time frame that's covered by the graph there. Has there been any change, I suppose, in what qualifies as obesity in that time, or are you going like for like measurement?
I haven't got that graph.
Neither do I.
Sorry, I don't know, Mark. I can certainly have a look at that, but I don't think so tremendously. I mean, you know, the scale of the fear that we've had in terms, and we're seeing it in diseases like diabetes in particular, you know, has been frightening.
Yeah. Well, I note you used the term an obesity time bomb. I prefer that to the obesity tsunami. That obviously conjured up an image of someone jumping into a swimming pool. You know, I'm concerned. Like, I know maybe 4 or 5 years ago, Safe Food were running a thing around obesity and tackling obesity, and they were just, it was there in black and white. If you're a male and your waist size is above 37, then you're obese.
Yeah.
And so I'm not obese.
Yeah.
Do you know what I mean? But they were that blatant and black and white about it, and I challenged them on it, and still, no, that's what's written.
Yeah.
That's the way it is. And I'm conscious of other issues, and they have been raised around eating disorders and things like that. And there's a huge problem I think now facing young males. It's often and always been prevalent for young women around body consciousness and pressures around that. But I think increasingly young males are feeling that pressure as well. I think sometimes we might just over-egg the obesity pudding a wee bit.
Yeah.
Okay.
Reverse for it. Just to say on that, I mean, if you look how we message generally, I mean, one of the things we try to do is not leave people with a problem that they can't solve, and it isn't about scaring or stigmatising, and we're quite careful about doing that. And the issue of the 37, 32 wasn't to say, you know, if you're there, you're obese. It's really to say, look, if you're seeing those changes, now's the time that you're going to have the best chance of doing it. And by the way, here are ways that you can do it. Here is help that is available, and we will help you through that. We never stop at giving a message out to people just to build awareness. And I think that has been where the science of the public communication has changed a lot for the better over the years. But it is to get that balance. Our measure is behaviour change at the end of the day, and it's behaviour change for the better. And we're in an area where we know there's a fine balance, often in everything we do, between, you know, doing good or potentially doing harm in that. And our real task is to make sure we keep on the right side of that. But often there's a hard message in what we're doing, because the issues we're dealing with require people also to take personal responsibility. And that's not a popular message to go out, but it's one that centres in public health. Public health is not the soft, cuddly bit of the health sector. You know, we are telling people, you need to step up to the mark here as well. You've got to take the responsibility, but you know what, we're going to help you.
Okay, thank you, Catherine.
Oh, thank you, Chair, and thank you, Eddie, for your presentation. Particularly the slides that we had. I think they're very informative and can help us moving forward. As a teacher, I've had direct contact with the Public Health Agency, and I have to certainly commend them, because I had them in on a range of issues, from bullying to mental health to exam stress, and the girls that worked with me from the Lurgan area were just absolutely fantastic, and the services, the information and the support they provided was invaluable, so the work that you do has to be credited. I'm concerned just probably about the slide that details the plus 46,000 avoidable deaths. The figures go up to 2011, so I'd just be interested to know, has that lessened up until now? That would probably just be my first question. My second question would be in relation to direct work with the Department of Education and the Education Authority in relation to education in schools, because obviously the earlier we let people know about health issues, then the better chance we have of preventing. And thirdly and lastly, Chair, just in relation to inequality in health, which I have grave concern about, and you have a slide here that details that if you live in a deprived area, you're twice likely to die from smoking, 3 times as likely to die from suicide, 4 times as likely to have heart or lung disease. That's really concerning, and particularly And I welcome the fact that you've also included the risk to the traveller community as well, and how the stark contrast of how they are more likely to die 15 years or 11 years younger, male or female. So what are you doing, I suppose, really to tackle those inequalities? And how are you reaching out to harder to reach people? Thank you.
We're really doing it on three levels. One, we target the programmes that will have the greatest impact, not only, I say, in terms of improving health and well-being, but also are at the root of those differentials. You know, this is why smoking cessation, teenage pregnancy and issues like that, sexual health, those issues have been focused on traditionally. So that's not been an indirect way of doing it. The other way has been directly targeting issues around poverty. And a lot of our programmes are doing that. I mean, and it's, you know, issues, for example, in MARA, which you might have come across with the Maximising Access in Rural Areas, which is a joint programme with the Department of Agriculture. It's been run for the last few years. And that's literally about getting more money in the pockets of people who are entitled to that money but are missing out on that on the basis of basic core issues of basic income. Add to that direct work in relation to fuel poverty. And then issue around, I've never found a right collective way of vulnerable groups or whatever, but it's groups that don't maybe fit in to general categories in that, or disappear off the graph because their conditions are just so different. And that, traveller community is one. You looked after children in that category. Homeless, we're dealing with prisons as well in terms of prison population, where the levels of health issues are just staggering. And we know there are so many complex social issues leading to that, but we've got particular programmes dealing with all of those areas as well, because it just needs a different approach. It needs an additional approach to it as well. But the key in this has also been about lifting the issues of inequalities into everybody's agenda, so that we don't have councils doing an economic plan in isolation from making sure that that is actually dealing with the same areas. Because at the moment, having people in employment and properly paid employment is one of the best things I can do for their health. And joining up those agendas at the moment has been more critical than ever. And it's making sure that the health and wellbeing agenda is absolutely part of everybody's agenda. And because we're in planning for real now, we've got those discussions are opening up now in ways that before, I believe we've got a better chance of getting that into practical joint action we've had before.
Thank you. And just, Chair, my first question, just in relation to
education,
up-to-date figures,
I'll give you that
decreased or?
That was my fault. So it was. I just took the wrong graph. It hasn't decreased that much. So it has, but I will provide you with
Brilliant.
the one. I've got the bubble in there. Sorry, that was
you.
just poor leadership on my part. There's that one.
Thank you. Paula?
Okay, thank you, Chair. And I'd like to declare an interest that I've worked for an organisation the last year that received Public Health Agency funding. Thank you, Eddie. Just a couple of questions. First of all, you had said that there were 600 community voluntary groups funded. That seems like an awful lot of mouths to feed, and I'm just wondering, are there going to be changes in this Assembly term in terms of trying to, modify that a wee bit in terms of, more impact and less spreading?
I think, over the last number of years there have been changes in that, some brought on by procurement and other things, which is a double-edged sword for us, because on the one hand it does give a chance to get a greater consolidation, but on the other hand the danger is that we move slightly away from locality and local communities. So the delicate balance in that. But I think that the real challenge has been to make sure that the 600 aren't swimming in 600 different directions. There's a coherence issue, a collaborative issue, which affects us as within statutory bodies, but is as big a challenge now, I think, for voluntary community sector. And it is just a way of having more impact from being able to join up. So certainly I think the trend is going for a smaller number, less of a scattergun approach. But I think our real issue is to make sure that that doesn't lead to a lessening of impact, and doesn't do, which I just think is, I think statutory bodies everywhere face this, and we are facing it as well, that, in trying to do the right thing in terms of having more impact in services, we actually move a step away from local communities, because out of those groups is a huge amount of the local capacity, particularly in working class communities. So we're very wary of that, very conscious of that, and it is an issue which is exercising us to get the right balance. So it is, we want impact, but we want impact for the long term as well.
Okay. The second thing really relates to the health of the nation sort of stuff, and around, lifestyle choices and as you say, the determinants. I'm just wondering how you're able to respond to all the different charities in terms of, where if you think of Alzheimer's or cancer and stuff, a lot of the factors are similar, but they all want their own campaign. And I'm just wondering how you're going to be balancing that. Yeah, it's a good question, because say our job is also to help people and help inform, and what we really try to do as well is help them to join up issues, because we do get them from just about every direction. And I can't blame it. I say I'm a president of a charity. I can understand when you're in that particular bubble. All you see is your own area and what can happen. We've also got to look at that, and this is where we can have we do have tough conversations on this. We've also got to look at the impact of bombarding the public with disconnected messages that add up to something that could actually get them to do the wrong thing. And we've also got to make sure that when those messages are coming through, that they're in a way where the services are ready to respond. So there's a filtering comes out of this, and we don't typically sit with getting with a wish list type of thing to say, come to us and we're going to find a way to put your message out there. The other thing which the past executive has done is you put quite a cap on public advertising anyway, so we really have to prioritise. So at the moment that those budgets have been decreasing actually over the years, and that's the public information side of things. So we've always had to work smarter in terms of getting a better return, and on that we've got to make some pretty cold calculations in terms of how we get the maximum benefit out of that type of activity. And looking at other ways, not only showing people how to use social media, but also helping them to do that and being a conduit for that. But, say, I can understand, my issue, I want to know why such and such got a campaign and I can't get one. Okay. And sorry, just the last one then quickly, and I'm not sure it's your responsibility, but the legislation around smoking in cars with children, is that under your bailiwick, or is that somebody else?
Well, it's not under my particular bailiwick, it's under the department's bailiwick. You can get them on that. But I have to say, I was part of that quite a few years ago. I think it was the people from Nova Scotia came over, who had brought in the smoking in cars issue there, and they'd actually come into this building to talk about their experiences. And that stage is really encouraging in terms of the results to it. I don't profess that any one legislative measure, but what we do know increasingly is that legislation, clear legislation, whether it's that, whether it's sugar tax or whatever, legislation in the context of the other issues does make a difference.
Thank you.
Thank you. We're glad to know we've got Pat and then Mark, and then that's us hopefully finished here. Pat,
thanks for coming, Ellie, and giving us some of your wisdom. I suppose everybody now knows the value of early intervention, and one of the issues I want to ask you about is breastfeeding. Because in spite of the benefits of breastfeeding and how it helps prevent childhood obesity, one of the things we were talking about earlier, among other benefits, we still have one of the lowest rates in the world. And there has been no significant increase since 2005. I'm just wondering, have you any plans to try and improve the statistics? Because I know I have a baby at the moment who is being breastfed. I have a 4-year-old who was breastfed as well. And I note in the annual report, one of the reasons given for the low rates of breastfeeding is the lack of support. And in my experience, the support has been absolutely brilliant with the community midwives. Any time there are any problems at all, they're out like a shot. My one complaint would be is sometimes they give different advice. You're not always getting the same advice from different midwives. But leaving that to the side, the support is excellent. My wife comes from the Basque Country. and the majority of mothers there breastfeed. You know, it's accepted
Absolutely.
culturally that that's part of their lifestyle. And I would hazard a guess, although there's nothing in the report, that the rates of breastfeeding in deprived areas are lower than in more affluent areas as well. So if we're talking about early intervention, this is one area where I think progress could be made if there was a strategy there, a plan or vision there to roll out.
I couldn't agree with you more. I think in all of our careers we've certain issues that are litmus tests about how ineffective we can be, and this is one of mine. In 1994, I remember chairing a meeting. I'd just come to the Department of Health at that time to stimulate action on breastfeeding, to make a big drive on it in time because we got the worst rates, and I'm sitting at this time and we're pretty much having the same conversation. It has been identified. We are working on public information campaign. I say we don't just do public information campaign on one level now at all. It's been an element of all of the work that we've been doing, and particularly in the issues of deprivation. So work, for example, on with young teenage mothers and the Family Nurse Partnership. That has been one of the key measures on that, and again to promote to make these things just an easier, natural choice for people, but also to get over the cultural and other issues that come in about that decision. Because I mean, the rationale is just so strong, but it is one of our ones for a big drive on it. We'll have to get better than we are at the moment. And as you say, when you look at Basque and other countries, that gives you an idea of just how far you can go, because they're faced with the same issues in terms of modern society, busy lives and issues like that. But definitely it is one of our key issues, and we will be working very closely with you on that.
Okay, thank you, Mark.
Just on the prevalence of breastfeeding in other countries, I remember before looking at it across the countries in Europe and thought it was quite ironic that the country with the highest or best rate for breastfeeding was Hungary.
Yeah.
That's true. It's true. You touched on the cap on expenditure on advertising. Could you go into a wee bit more detail on that, on what it is? And I do have some recollection from the executive that I think an exemption had been made around DOE, road safety advertising. But if you look, I suppose, at year on year the number of deaths by suicide across the north there, much more than lives lost on the roads. Would you think there'd be a case to make an argument around maybe specific campaigns on specific areas?
Yeah, I don't know too much about the history of it. I just know that whatever way, I mean, it would have been through the Assembly Executive in some way, but certainly the way it is translated into us, you're right, road safety got an exemption on it. That didn't apply to us. The issue for me, again, is that I do not want money being given to us to do stuff that doesn't have impact. It's not to make that side of it soft, but what clearly, from the point of view of the return, both in terms of the potential for lives saved, I would say public health needs to be there. It's now backed by evidence and science, which is streets ahead of where we were before. Not only do we know how to target that information, but we know from other countries and other places just how much it works. And the big issue for us is that it's sustained information. But our issue, Mark, is that what I would always be concerned about looking forward is that we get the balance right, because we've done stuff in organ donation, like to keep going stuff. We can't keep everything going at the one time, and as we grow new ones in, I don't expect this to just go exponentially. But certainly from our point of view, it's an issue of just, I suppose, also from our point of view of being able to articulate in a better way just why this stuff matters and works, and are very happy to provide more on that to yourselves or others.
I suppose you'd have the evidence to back up the effectiveness of campaigns that have run, albeit on a limited basis like that. Where's your head at
We've got, yeah, we do meticulous research before every campaign, and we also do the evaluations after. Now, some of those we're just getting the first part of it, but we also can tell, certainly from WHO's information, you know, in terms of which areas, you know, smoking in particular, we're very clear. It's a sustained message that really has the impact, so it doesn't look like a dip in, dip out. We'll, you know, because we like between the campaigns to make sure that people haven't forgotten the message by the time we restart it.
Yeah, and one other issue I've raised it a couple of times over the past couple of months, I suppose, and never really been able to get answers on it. And I know Paula raised some of the points in the debate during the week in the chamber, and it was around the impact potentially on your work of an exit from the European Union. You've spoken a lot about collaboration and collaboration, working with other agencies, but I do know particularly enough around border areas and be caught in that there would be a lot of work with your counterparts in the south. Do you any impact at all?
Well, I mean, we're trying to get our heads around it. I mean, we've got three areas of us that are very strong European connection to it. COT, it is one of them because that's a channel for Interreg money. We've got our R&D World, it's an international world. It's not simply a European one, but that link over the years has been developing with our office in Europe. And those emergent areas in innovation, the likes of telemonitoring and that, which tend to work, again, it's broader than Europe, but there's a strong European alliance element into that. I mean, the issue is, you know, I think like everybody else, but just don't know. I know when the advice is coming out, which is very much telling us, look, you know, long lead into this, just, you know, we're not quite sure what the status is of particular programmes as we go forward, but you know, keep the underlying work going, you know, with where we can. So I mean, I've been watching the TV just to find out where we're going all of this here, but you know, we're not clear. But those are the main areas that are likely to be affected, and we're looking at it very carefully ourselves just to try to assess that, particularly in issues like whether the big programs like Interreg, because they've been an important element of tackling a lot of the issues we've talked about.
Okay, thank you.
Okay, thank you, Mark, and thank you, Eddie.
Thank you very much.
Good to have you here with us, and no doubt we'll be seeing plenty of you
thank you.
as time progresses, so thank you.
Thanks very much.
Thanks. Okay, members, we're going to move on to item number 6 on our agenda, and that's an overview briefing by the Health and Social Care Board. May I advise members that the Chief Executive of the Health and Social Care Board is here today to brief the committee on the work of the board, including current work streams and priority. And can I refer members to pages 111 to 184 of the meeting pack? Hello, and you're very welcome.
Thank you.
How are you? And I'll probably just hand over to you to go ahead.
Okay, better get my glasses on here. Well, good morning, Chair, and also good morning to members of the committee. I recognise there's a few familiar faces around this table. And I too would also like to very much thank you for the invitation to come along today to try to give you an overview on the work of the Health and Social Care Board for Northern Ireland. As many of you, and I'll try to be as brief about that as possible, but we do cover a lot of functions in the board. As many of you are already undoubtedly aware, the board was established back in April 2009, established back then under the review of public administration, and that resulted in the coming together of those functions that were previously performed by the 4 area-based health and social care boards into one single regional organisation. And the reorganisation of those 4 boards into one delivered substantial efficiencies at that time in terms of the establishment of this single regional body. Clearly we work very closely alongside our colleagues in the Public Health Agency, as well as with colleagues in the department and indeed across the 5 trusts, along with our GP colleagues and the community and voluntary sector representatives. But all of that reorganisation back then resulted in a much more effective and consistent approach to the whole planning and designing of health and social care services for the entire population that we serve here in Northern Ireland. In my own personal opinion, I think local involvement in the whole commissioning of health and social care services is absolutely essential to reflect local circumstances, and the board has continued to ensure that local involvement through the establishment of 5 local commissioning groups, and those 5 local commissioning groups are coterminous with the 5 health and social care trusts. And as a result of that, board staff are then find themselves based in a number of offices. Although they work for the board, we have staff that are based in Linen Hall Street in Belfast. We also have staff working from Grantia in Derry, Londonderry, and staff based in Armagh and also in County Hall in Ballymena. Back in 2009, the Health and Social Care Reform Act, under which the board was established, identified then 3 core functions for the board. Firstly, the board was given the responsibility for the commissioning of health and social care services. Secondly, for managing the performance of health and social care trusts. And thirdly, for ensuring that resources that are allocated for health and social care are used in the most economic, efficient and indeed effective way. The Act also requires the board to work very closely with the Public Health Agency, as Dr Rooney has just outlined for you previously. And in particular, we need to work very collaboratively in the development of the annual commissioning plan, which requires the board to have due regard to any advice and information provided by the Public Health Agency. That commissioning plan requires the approval of the board of the PHA and also the non-executive director board of the Health and Social Care Board, which is then passed back to the department and to the Minister for final approval. As I've said, and I stress again, it's absolutely essential, and Dr Rooney and I both recognise this, as do all of our officers that work in the Public Health Agency and the board, that it's that close collaborative working piece with all staff across the 2 organisations in the integrated teams that we have formed. It's through that work that we jointly address the challenges we face to improve the services delivered to the local population. In particular, the 2 organisations work very closely and effectively in relation to the whole patient safety and quality agenda, and at the same time ensuring that any regional learning is identified and disseminated throughout the whole health and social care system to improve that experience of service users and indeed the safety and quality of all the services that we provide. So I think it's actually quite fitting that Dr Rooney and I have been invited to present to the Health Committee at the same time today. So it's under those broad headings that I've already outlined, that is commissioning of services, managing performance and resource management. It's under those 3 broad headings that the board carries out a very wide range of functions and roles. It's not my intention to dig down into and outline for you ad infinitum today what all of those individual roles and functions are. But I did circulate a paper that the board prepared to help inform the discussion on the future restructuring of the health and social care system, which provides more detail on many of those functions, and I hope members have found that paper useful. I am, of course, very happy to provide more detail in any one of those areas that I outlined in the paper to the committee, or indeed to any individual member, if indeed you would find that helpful. But I'm just now going to attempt to give you a very brief overview of some of the critical work that the board carries out. Clearly, we're responsible for ensuring that the health and social care needs of the population are fully assessed and that a wide range of services are put in place to meet those population needs, clearly being cognizant of equity and fairness and working within what we still consider to be a constrained budget. I'm often asked, Mrs Watts, do you have enough money to provide the health and social care services across the province? And my standard answer now is, can you ever have enough money for the provision of health and social care with the introduction of new drugs, new treatments, new technologies? It seems to me almost every minute of every day. But the key functions that sit within the commissioning directorate is about assessing population health and social care need and planning health and social care services around that need. We also work on the development of health and social care service models. We are in the business of procuring health and social care services and then monitoring and evaluating those services. And also we have a number of officers that their expertise, individual expertise, is called upon at time to set up regional services when we think that is appropriate. In terms of the other services that we provide, the board also ensures, under the heading of specialist hospital services, we try to ensure equitable access to highly specialised hospital services for the whole population of Northern Ireland, hopefully delivered to nationally accepted quality and safety standards through what we call resilient service models. This role that we carry out supports the retention, where safe and effective to do so, of specialist hospital care within Northern Ireland, supported by formally established networks, and also technological innovations, peer review, benchmarking and integration with larger tertiary and quaternary centres in Great Britain, the Republic of Ireland and indeed Europe. The board also specifies and reviews the components, standards, access arrangements and outcomes expected in the delivery of specialist care in Northern Ireland, looking at the efficient use of resources and the strategic planning and budget planning to ensure services remain modern and responsive to the challenge of delivering high quality clinically complex care to a geographically diverse population of approximately 1.8 million people. We also ensure that models of service underpinned by appropriate evidence of cost effectiveness are broadly consistent in localities right across the province, with minor variation in the context of particular local circumstances. So we're taking that, trying to always ensure that regional perspective in terms of the services that are provided. We also translate broad departmental policy directions into detailed implementation plans, setting out how, where and by which organisations services will be delivered equitably across Northern Ireland. The board also oversees the implementation of these plans, providing support to the providers and dealing with the myriad operational issues that invariably can arise. In terms of the planning and management of family health services, we're also responsible for strategic planning and managing general practitioner, dental, ophthalmic and pharmacy services. And that responsibility also covers the development of integrated care partnerships, which I'm sure many of you are undoubtedly aware of the good work being carried out by the ICPs, and driving forward integration throughout the system. The key functions under that family health services banner that we carry out cover general medical services, GP out of hours services, general pharmaceutical services and medicines management, general dental services, general ophthalmic services and the primary care infrastructure development programme. Just moving quickly on, a central part of the planning and commissioning of effective health and social care services is undoubtedly around the sound and robust financial management of those services. And the board provides a very wide range of comprehensive support to enhance health and social care in terms of financial control and performance management, financial management for family health services, and also regional finance functions. Just again, moving swiftly on, the board plays also a very important regional role, I believe, in identifying and securing opportunities to improve the efficiency and effectiveness of service delivery by the provider organisations. And this is obviously under the banner of performance management and service improvement. And through that, trying to secure the best outcomes for patients, as well as always VFM or value for money. And we try to do that through the identification and sharing of best practice and auditing the implementation of the same. So performance management, information management and analysis, looking at service improvements, and also in particular keeping a watchful eye over the delegated statutory functions are also a core responsibility for board staff. Those delegated statutory functions, we have oversight of trust compliance with the statutory functions as set out in the legislation, which confers powers and duties on the board which are delegated to us under an approved scheme. There are reporting responsibilities around all of that to the department, and that's obviously set out in a series of circulars across a range of service areas. The Delegated Statutory Functions Scheme describes the fundamental principles, values and accountability relationships that will underpin the delivery of services, and the powers and duties which the board has delegated to the trusts under the following legislation. And that covers the Children Northern Ireland Order 1995, the Adoption Northern Ireland Order 1987, the Mental Health Order 86, Disabled Persons Act 89, the Chronically Sick and Disabled Persons Act 1978, and last but certainly not least, the Carers and Direct Payments Act of 2002. But in relation to the Social Care Directorate that sits within the board, a critical function of that directorate is clearly about trying to build social capital, and that's underpinned by 4 core objectives. Firstly, trying to empower communities, families and people to take control for their own health, their social well-being and their own personal circumstances, and clearly Eddie has been questioned and given answers to the committee around how we engage with local government and other key partners across education, housing, to try and bring about and help empower communities further to do that. Another key objective of the Social Care Directorate is in improving outcomes through the systemic application of evidence-based practice across social care. And thirdly, enabling partnership working through the co-design of care services or co-production of care services. And lastly, aligning resources on all of those interventions which reduce the impact of adversity across the life course to improve quality of life and reduce unnecessary demand on high-cost intervention. I'm nearly there, Chair. We have a big role to play in ensuring safety and quality of services and securing learning from that I've already touched on. And a number of key functions carried out by the board working jointly with the PHA cover the looking at serious adverse incidents, learning from that, child death notifications, safety and quality alerts, and indeed, last but not least, and very importantly, looking at complaints that are registered about health and social care services. I'm not skipping over any of that. You may want to come back and question me on some of that. The partnership working and supporting system reform under the banner of Transforming Your Care. Clearly, the board had a leading role in taking TYC forward and in overseeing the implementation of the 99 recommendations that sat within the Transforming Your Care report. But it shouldn't just be about those 99 recommendations. Transformation and reform should be underpinning absolutely everything we're doing right across the health and social care system. And should be embedded in everyone's day-to-day, I think, job description, to be looking at ways that we opportunities for reform and transformation. But under that heading, we have provided system leadership for some of those major initiatives, and we also lead on multi-agency partnerships and that collaborative working piece, and also looking at how we develop technology to support health and well-being. The board are also responsible for developing the e-health strategy, which sets the direction on how technology can better support health and well-being across the system. And that particular strategy sets out key objectives around supporting people, sharing better sharing of information, using information and analytics, and fostering innovation where we can through technology. And clearly all of that underpins the transformation and reform agenda as well. So just in finishing, Chair, I just wanted to cover with you or give you a brief overview or touch on some of that reform work that the board is now progressing on behalf of working in partnership with the rest of our colleagues across the HSC. And that specific work is being taken forward in relation to unscheduled care services and also on elective care services. In relation to reform in general, the focus of the board during my time as Chief Executive, and that will be 2 years tomorrow, it's my 2 years in post tomorrow, it's been a very interesting and very challenging 2 years, I can tell you. But in relation to reform in general, the focus of the board during my time has been on ensuring the timely and effective implementation of the recommendations set out in Transforming Your Care. And whilst good progress has been made with the implementation of those 99 recommendations, it is abundantly clear to me that both the pace and the scale of change needs to increase quite dramatically if we are to ensure that patients and clients have the care and support required to allow them to live longer, happier and healthy lives, certainly within their own homes and within their local communities. And I think the achievement of this aim will require a fundamental shift in our collective focus, working with individuals and local populations to better understand their particular needs through the work of the integrated care partnerships and indeed other arrangements working across the statutory and community and voluntary sectors to ensure that the necessary services and support systems are in place. And I'm the first to admit that we have a very long way to go on that. But consistent with this wider approach to reform, the board and the PHA are jointly leading the new regional and local network arrangements to improve unscheduled care services. And a central focus of those arrangements is on ensuring that services are in place to avoid the need for patients clearly to be taken to hospital. And we're working to enhance both the range of community services available to help people to remain at home and to ensure the better integration of those services. The overriding aim here is to provide care for people at home or as close to home as possible. However, there will be nonetheless be occasions where access to more specialist unscheduled assessment, diagnosis and treatment services will be required, and typically that will have to be in a hospital setting. The board and the PHA are working very closely with our trust colleagues and through the wider ICP networks to secure greater consistency of service provision in relation to ambulatory care. And within the available resources, we are seeking to improve ambulatory services for unscheduled care patients and to explore opportunities to use same-day or next-day models as an alternative to existing outpatient clinics for planned patients. But with even more effective services in the community to allow patients to remain at home and at the front door of hospitals, there will continue to be some patients for whom admission to hospital is the only appropriate avenue and indeed the safest option. Just very quickly, and I'm coming to an end now, is in relation to elective care services, improving waiting times again has been a key priority for the HSC, I'm well aware, for a long number of years. Elective care waiting times remain broadly unchanged from 2009 to 2014, albeit there were challenges in particular specialities. However, the position deteriorated significantly from the second half of 14-15 due to the wider HSC financial position. And prior to this, maintaining the waiting time position had been heavily dependent on the availability of additional non-recurrent funding to enable trusts to undertake additional activity in elective specialities where there was a gap between funded health service capacity and patient demand for assessment or indeed patient demand for treatment. Given the scale of the gap between capacity and demand and the lack of additional funding in 14-15 resulted in a sharp increase in elective waiting times from mid-2014. Clearly, substantial additional funding was received in mid-November 2015 to address elective waiting times in year, and that was indeed very welcome. And over 80,000 patients benefit directly as a result of this additional funding, and patients who were previously on waiting list for assessments or diagnostics and a range of other services, and some had been on those lists for a very long time. The funding secured in November 2015 resulted in a rapid but short-term reduction in waiting times, and while this did benefit a large number of patients who would otherwise still be waiting, managing elective waiting times with short-term funding does not provide a sustainable solution. And we all recognise that there's a need for a longer-term solution to manage demand for elective care services and to deliver sustainably shorter waiting times for those patients. And to that objective, the Department has asked the Board to develop a plan to reform how elective care services are delivered here in the province and deliver sustainably shorter waiting times. So that plan is nearing its final draft stage as we speak, and I'm hoping that we can have that plan with the Department very, very shortly. And finally, committee members will be aware of the work that's taking place to design new structures for the health and social care system, following the previous Minister's announcement last November, in which he indicated his intention to close the Health and Social Care Board. I've already mentioned the paper that we prepared in relation to the consultation on the review of those structures, and that's the paper I've shared with you. And that was intended to help inform discussions on any new structures being taken forward. I have to say that whilst that announcement understandably caused considerable distress and uncertainty at the time among many board staff, I can assure the committee that as an organisation we are totally committed to working with the Minister, her department, to design, and this committee to implement the best possible future structures to support the delivery of the best possible health and social care services for all of the people in Northern Ireland. And indeed, I have been immensely impressed by the professionalism and commitment shown by board staff to achieving that outcome in all of the work that I have experienced them doing over the 2 years of my tenure of the post. And the previous minister consistently said that the restructuring wasn't about people or organisations, but about designing the system in a way that reduces unnecessary bureaucracy and aids innovation and faster decision making. And we in the board are totally up for that.
Okay, thank you, Valerie. That certainly was a very informative, high-level overview of the board, and I think that will have been helpful for many of the new members, as well as many of the members that have sat on this committee as well. I know in the last mandate there were only a few occasions that I ever had to maybe go and meet with the board or facilitate meetings, and I always find them extremely helpful. May not have got the outcomes that I wanted all the time, but that's fair enough. We learn to accept that. But I did find their professionalism and their helpfulness. It certainly helped me in my journey as an MLA.
Thank you.
So thank you for that. You had mentioned a few things I just wanted to pick up on before I bring members in. One of them was, I'm glad to hear about the waiting times and the plan that's going to be put in place. I think we're crying out for that. We really do need that, and we need to have something better in place to manage that. And we know there's been various reasons during the mass mandate as to where we ended up where we were, because this has always been, this has been since time immemorial. This is not something new, albeit that it has escalated, so I'm very glad to hear that. You also mentioned there a little about the adverse incidents. And I know in the Donaldson report he had talked about a way of reporting and a new way of reporting on adverse incidents. Have we made any strides in working towards a better way of reporting on that?
We take the reporting of serious adverse incidents very, very seriously indeed. In fact, I have a dedicated slot on my senior management team meetings every Tuesday for us to do a deeper dive into each and every one of those serious adverse incidents. We're working very closely with the Director of Nursing within the Public Health Agency, and indeed the Director of Public Health, on making sure that we leave no stone unturned to get the learning from those incidents and spread that learning then right across the whole system, and try and share that with everyone who needs to learn the lessons from each and every one of those serious adverse first instance. So we're working much more closely with the PHA, with colleagues in trusts, and indeed with GPs to, that's going to be a continuous improvement journey for us all the time, the learning from all of that.
Another issue that was mentioned when talking about that was also the complaints and the level of complaints. I know from working on the other side as a member of the health service about complaints, and I also know as an elected rep, as we all will, when people come to our office, and quite often there's a very easy solution to many things, but sometimes there are things that really do require that we step in and we do act on behalf of our constituents. What's the level of complaints? Are we seeing a decrease in that, or?
I have to say that in terms of those complaints that cross my desk, I have seen in the last, I'd say, year, less of those types of complaints coming to me, but every single complaint needs to be treated in the same way, whether it's a serious complaint or something of a minor nature or someone's opinion about the service that they have received. Every complaint is, to me, is a valuable piece of information for the health and social care system. I have to add that quite often I receive as many complimentary letters about the services that are provided, particularly by GPs and colleagues out there working across the 5 health and social care trusts. And I keep quite a large file of those letters as well, because it is nice when the going gets tough to sometimes reread some of those compliments where lives have been saved by clinicians or lives have been improved through the work of social workers or GPs, and to remind us of the good work that is done day and daily throughout the whole HSC.
So I remember we had a witness session here in the last mandate, and looking at the complaints, and very much so a lot of those complaints could have been avoided through better communication, because I know certainly being on the other end of the side where MLAs were writing into my department about complaining about something I may have done or didn't do, and quite often when you sit and think about it, communication, and I think that's something that has rolled out. And we are seeing better communication with the different disciplines and clinicians, and hopefully that is helping to bring that down a bit. But you're absolutely right. I used to say for every one complaint that you maybe saw coming through the door, there were 500 others that were saying they had a good hospital experience or a good experience. We mustn't forget that either. You had touched upon managing the transformation and the restructuring and how that might look as we go ahead. And I think it would be helpful if you could maybe just outline, just briefly, the key priorities that you see for yourself within the coming months and years ahead.
I think from where, having spent 2 years in the job and a challenging 2 years at that, I see a fantastic opportunity ahead of us just now. I think all of the stars are aligning in that we have a new programme for government. We await the outcome of the release of the expert panel, Professor Bengoa, headed by Professor Bengoa, his report. There is a real collaborative piece of working going on amongst the senior managers and leaders within HSC, including staff from the board, in trying to identify new organisational design options or new operating models for health and social care. And we have the advent of community planning, and having worked in local government for 26 years in Scotland and saw the advent of community planning back in the millennium year, back in 2000, and worked with that right through until I left Aberdeen City Council to come back to Northern Ireland to do this job back in 2014. I'm quite excited by all of those different events all coming together. And I think there's a big opportunity that should not be missed by those of us who work across HSC and working with other departments in government. Because as Eddie said earlier, that whole making life better piece isn't just about improving health and social care outcomes, but that is determined also by good housing, economic generation in terms of job creation, about education opportunities for children and indeed all of the people in Northern Ireland, and just working, that collaborative working for collaborative gain is how I best describe it. And having seen the introduction of what we call single outcome agreements in Scotland on the back of community planning for local areas, and a coming together of all of the key decision makers that represent that sit within a particular council area or whatever, and some of the very exciting debate and dialogue that ensued as a result of some of the big, difficult issues that communities were facing, and how that collaborative working piece can actually deliver fantastic results that end up making life better for the residents in those local communities. So I think the timing, it's really quite an exciting time to be working in Northern Ireland and in government and in the public sector with all of those different, that alignment of all of those different things that I've just outlined.
Okay, thank you, Barbara. Okay, I have three members who have down for questions. That's Joanne, Catherine and Paula. So if anybody else wants to come in, if they can let me know. Joanne?
Thanks, Chair. Thank you for your briefing. Valerie, I don't in 2 years in post tomorrow, well, to congratulate you or commiserate with you. One of the issues which concerns me is the under-delivery by the health trusts on what has been commissioned for elective care, and you touched on this because obviously this is a concern with the board, which the board has, if you spoke of a plan which will be with the department shortly. How far back do you feel there has been a gap between what has been commissioned and what is being delivered? You did speak of challenges in specialities in elective care. Which specialities? And also you spoke of rapid but short-term reductions in funding with regard to November 2015. So could you give us a wee overview on that and concerns? Into that plan?
That covers quite a range, and I'm going to be, I know you want me to be succinct here because I probably sit between you and your lunch, but I need to refer to my briefing note here just for some of that to give you as comprehensive an answer, Joanne, as I possibly can. The increase in waiting times during the first 9 months of financial year 15-16 was due to a combination of different factors. Primarily a continued increase in demand for elective care services. Also, and as you rightly point out, an under-delivery of commission volumes of core activity by trusts across a range of those specialities, some of which you have just mentioned. But also the unavailability of non-recurrent funding to enable those trusts to undertake additional activity to maintain waiting times in those elective care specialities, where there was an agreed recurring gap between demand and indeed funded capacity. The reduction in the number of patients waiting longer than the maximum waiting time standards for elective care during the latter part of 15-16 is as a result, undoubtedly as a result of the impact of the additional activity associated with the non-recurrent funding that was allocated in November 15. This funding was used by trusts to undertake additional activity both in-house and clearly also by the independent sector during the final quarter of the year, with the majority of that activity actually being carried out in February and March of this year. And that activity was targeted at those patients who had been waiting the longest for assessment or treatment, as evidenced by the level of reduction in the number of patients waiting longer than the maximum waiting time standards and those waiting longer than a year. If the increasing trend seen in the first 9 months of 15-16 had continued, around about 189,000 patients would have been waiting longer than 9 weeks, and around 39,000 patients would have been waiting longer than 13 weeks for treatment at the end of March 2016. And the additionality associated with the non-recurrent funding reduced this forecast position by about 54,000 9-week waiters and about 6,000 13-week or people who had to wait 13 weeks. In addition, a substantial number of patients seen in 15-16 as new outpatients and who require surgery will be treated and have been treated during the first part half of 16-17. and trusts have been asked to put arrangements in place to continue to undertake additional in-house activity during Q1 of 16-17. We refer to those core volumes that sit within the strategic and business agreement which each of the trusts, and those core volumes are set for each of the specialities, and those are benchmarked against Royal College guidance. At times, I have to admit that we have to, we enter into long discussions with trusts about their ability to reach and achieve those core targets. I think it's fair to say that we are entering a new era, and we need to be scrutinising those targets in a lot more detail and making sure that both realistic but also challenging targets are set for the trusts in relation to those SBA volumes. Just in relation to diagnostics, the number of patients waiting longer than 9 weeks has continued to reduce during the final quarter of 15-16, and I know you have a particular interest in breast radiology, particularly within the Southern Trust. I'm pleased to say that we had a very good meeting with Trust Chief Executives this week, where Frances Rice shared with me some of the very specific actions that they're taking to ensure the continued provision of safe and effective breast services. I can send you all the information you require on the elective care waiting times. There's a lot of information I could share with you today, but I'm happy to do that in a separate briefing note for you if you find that helpful.
Okay, sure. Yep. Okay, thank you. Catherine?
Thank you, Chair, and thank you, Valerie, for your presentation. I just want to really raise a concern around staffing levels. I know I met with the Southern Trust along with John O'Dowd, my colleague, a couple of weeks back, and there's huge concerns there. For example, and it's been well raised, a huge proportion of our newly trained nurses tend to go to England to work, around 20%. We're losing consultants as well. But something that's probably more concerning for me is that my Trust Chief Executive raised the fact that consultants are moving within board areas, because if Belfast Board can offer a consultant in the Southern Trust a better package, then they'll go. And I really think we need to manage that. I don't think that's okay, because it means that the Southern Trust then are the poor relation, and I'm sure it's being felt across the other trusts. So I'd really want that tackled, that just isn't the normality, and that just can't happen. And we also, as you know, and I'm sure you're aware, have a severe shortage of GPs, which is putting huge pressure on our out-of-hours and also our A&E. So it's really just to see, I know that you're more than aware of it, but what we're doing to tackle it and to try and sort of keep our nurses here, and also to restrict movement from consultants who may see Belfast as a much more appealing option.
At the very same meeting where we were discussing the issue around the shortage of breast radiologists in the Southern Trust, really the key purpose of that meeting with the chief executives on Tuesday was to talk about workforce planning and indeed succession planning matters generally right across HSC. I know that there are particular concerns within some of the trusts at the minute about the shortage of junior doctors from heading into August and onwards, and there was a complete agreement at the chief executives meeting that we need to be less competitive with each other in terms of drawing staff between one trust to another, and there needs to be more of that collaborative piece. And certainly around where there may be issues of patient safety or quality in relation to those services that we provide. If they're to be affected in any way, patient safety or quality is to be affected adversely in any way because of staff shortages, then it is absolutely critical that the trusts work together to ensure that we put in place the best regional arrangements to ensure that people are not kept waiting any longer than they should be kept waiting for important red flag or serious diagnostic and ultimately any treatment that they require. So I was very, very encouraged by the collective effort that I witnessed of all the Trust Chief Executives at the meeting on Tuesday to working better together across the province to ensure that any staff shortages, we're addressing them from a regional perspective.
Thank you. Okay, Paula?
Okay, thank you. Thank you, Valerie. I just like to declare another interest that I was on the Belfast Local Commissioning Group the last year. And it's on that basis that I want to be talking about the commissioning, the annual commissioning plan, and I raised this with the departmental officials who came a couple of weeks ago about the absurdity that it's not defined by the start of the financial year, and it follows into that, and I'm just wondering how that can be dealt with in the context of the new service models that are commissioned during the course of a year that sometimes are delayed in getting off the ground because the workforce planning is not in place and that the personnel aren't there. And we're just wondering if you could comment on that in the context of possibly getting longer funding, the 3-year funding packages.
This certainly is like music to my ears. It's an excellent question, and again, in my opinion, there is an absolute need to move the financial planning around health and social care onto a much longer time frame. 3 to 5 year plan would be ideal, in my opinion, because we await the commissioning direction from the Minister, then we start to draft the commissioning plan. That commissioning plan has got to be approved by the board. My board, it's then got to go to the PHA to be approved, and then it goes back to the department for their final approval. Then all of that has got to be underpinned by a really strong financial management regime. That then leads us into receiving trust. The trusts then get their financial allocation. We then in turn receive their trust delivery plans, and then we get into the business of trying to agree and get sign off on the strategic and business agreements. All of that takes quite a long time, and to do that, have to go through that iterative process every single year. It is a bit like, it's not as efficient as it could be, and I would wholeheartedly agree to that. So we are working very closely with colleagues in the department to see if we can move that whole system into a much longer planning time frame that would then certainly free up that resource that's required to produce all of those plans every year, to allow them to get down to delivering real improvement in terms of reform and transformation on the ground.
Yeah, well, I think the other part was really about having the specialists and clinicians there to actually take up the posts once they've been commissioned. I think that there's been problems in terms of recruitment sometimes, and I think it's further delayed that. I think just the other point I would make is I am concerned, it's more a statement than a question, I am concerned about the abolition of the Health and Social Care Board. I always liken it to the abolition of the Education Authority. You know, I just don't see how the department, in terms of the core functions, how they can balance that in terms of holding to account performance management and stuff. I'm just wondering if you can give some enlighten us as to how the new structure, how things are going to change so that those functions are protected and aren't too influenced by politicians as such.
Well, in the paper that I circulated to all members, you'll see that some of those design principles around what we do, how they need to be thought about and protected moving forward with the design of any new organisational structure. Having worked in the public sector for some almost 34 years now, I've got more T-shirts around organisational redesign and restructure. But I think that I really believe that the design of any new HSC organisation or organisational design should start with some corporate self-reflection. And I think we need to be asking ourselves a series of questions around, what is our sense of purpose, how we're going to make a difference to ensuring better health and social care outcomes for the population. Also some things around what do we need to do now in relation to HSC organisational design to ensure sustainability of service delivery moving into the future. and also what would be the differentiating capabilities that we need to have in place to allow us to deliver a health and social care value proposition over the next 5 to 10 years. I also accept that for many of us working in organisations, these large public sector organisations, that answering those questions may at times prove a bit difficult for us personally, because it means going beyond our own comfort zones. And I think this is where staff in the board are feeling a little bit vulnerable now, because you know, some of them are very worried about where they're going to be placed in the future, and indeed will they have jobs. The Permanent Secretary did a very, he came and spoke at each of those board locations to staff and gave them a number of reassurances which certainly helped to settle some of the fears and concerns that staff had. But I also think that it's right for us now to set a bold new direction looking at organisational design of HSC, and I think we need to all work together to marshal the HSC towards that goal of delivering better outcomes, and then prioritise everything we do accordingly or around all of that. Over my years in management positions, I've seen a fair number of organisational design initiatives fail to make a difference, because as senior executives, it's only natural that we tend to get caught up in discussing the pros and cons of old ways of working or existing ways of working. And I think that in order to make progress, we need to avoid talking about the past, and we need to start almost by declaring an amnesty for the past. And collectively, we need to spend time on designing the best possible organisational structures which will underpin the delivery of those commissioning plans, the programme for government, and allow us to freely engage with other stakeholders in that making life better agenda to bring about improvements. And I also believe that as senior executives, we should be held to account for what specific actions have we taken in the last month, in the last six months, to remove some of those barriers or hurdles that's stopping us making life better for the people in Northern Ireland.
Thank you.
Okay. Gary?
Thanks, Chair. And it's a quick question, because Valerie did touch on it there, so it's really a supplementary in respect of issues for staff, because as MLAs we have, I'm speaking probably on behalf of us all, we've been approached by staff concerned about, particularly in my area, about relocation and whether they will be staying there, whether they'll be going, whether they'll be moving to other areas of Northern Ireland. And it's about getting the reassurance from yourself that there will be clear communication, because I have heard that there's a feeling on the ground, if you like, those staff who are sort of on the ground, they're not getting clear communication about what's happening, and I think it's important that they do get that clarity, because obviously it's uncertain times for themselves.
I have a kind of an audit of all of the pieces of communication that I certainly have sent out to, along with my head of comms, along with each of the directors, and we have at no time held back on giving staff information when we feel we have information to give them. The chairman of the board, Dr. Ian Clements, and myself have, I think, on 3 different occasions now gone out and done the round of staff meetings. We've also held video conferences with the other offices where it's not practical to get out and give the same message to all of the board staff on the same day. And indeed, as I say, the Permanent Secretary engaged in a very worthwhile round of meetings with staff and gave staff a number of reassurances around this is any reorganisation or any change around organisational design is absolutely not about centralising services in Belfast, and really spoke, very positively about ensuring that those jobs, some of them very highly paid jobs, remain out in each of those regional offices, and they're not pulled into the Belfast area. Obviously, we can't stop staff leaving or applying for jobs in other areas, and we are seeing a bit of that at the moment, where some board staff are still a little bit unsure about where they see themselves fitting into the structure or applying to go and work, perhaps in trusts or in other parts of the system.
Well, I think that's useful, and not to offend my Belfast colleagues, but not centralising services in Belfast is the key bit that I wanted to hear, and I think that's the bit that those staff employed in the likes of Greenwich House and those in the Western Trust want to hear. So I think that's welcome. Thank you.
Thank you.
Okay. Finally, Mark.
I'd certainly share Gary's sentiments in that regard. And I suppose I appreciate all your endeavours in terms of reassuring your staff, Valerie, but it's difficult for you to give reassurance, I suppose, unless you have it yourself. So I think it's vital that, I think I can quote you to say that you were tremendously impressed with the board staff and how they were up for working with the department to get through this into the new structures. Are you equally impressed by, I suppose, the department's commitment to work with you on the design of new models? And given all the questions that you have to ask yourselves, and we all have to ask ourselves about what sort of new model we want or how we want these services to be designed, and we have to be asking ourselves those, and then we'll have to answer those, or someone will have to answer those. Do you think perhaps the decision, or at least the announcement and timing of the abolition of the board was maybe a wee bit premature?
I've been very encouraged by the department involving the board in any of these design discussions or negotiations or workshops that have been set up, and board staff have contributed to that very frankly and indeed fully. And at the last workshop that was held just a few weeks ago, there was really a fantastic and a great and encouraging and heartening dynamic across all of the senior leaders working across the whole HSC system at that workshop in discussing at length each of the models that were described for us on the day, and almost all coming to, in fact, I think everyone came to the general consensus on what some of those preferred models would look like. So I'm beginning to sense some real traction in relation to how the department are leading on these design or the design of the new structures, and we at all times have felt fully included in those discussions.
Okay, members. Thank you, Valerie, for a very informative session, and I'm encouraged by some of the words that you've said today and moving forward. So thank you very much.
Thank you, and thank you for your time.
Okay, members, if we could move swiftly on then to item number 7 in our agenda, which is the Forward Work Programme. And can I refer members to the draft Forward Work Programme at pages 186 to 187 of your meeting pack? Are members content to note the Forward Work Programme?
Content, yeah.
Thank you. Item number 8, matters arising. Can I advise that I have no matters arising at this time? And move on to item number 9, which is correspondence. This can be found at pages 192 to 265 of the meeting pack. Can I draw members' attention to correspondence items 9.6 and 9.7 in respect of the timelines for developing the programme for government and budget for 2017 to 20? In view of the light of timescales involved, are members content that we write to the department to ask to inquire about the committee's opportunity to input to the development of these documents? I propose we would seek information from the department on the department's anticipated budgetary requirements, including its baseline position, spending pressures and priorities, any proposed efficiencies and linkages to the programme for government. And can I ask, are members otherwise content with the proposed actions as listed on the correspondence sheet at page 190?
Chair, one issue, just correspondence 9.2, Mrs. Dinah McKinney. Could I also point out that I have been working with Mrs. McKinney and her family, and last week held a meeting in my constituency office with Mrs. McKinney and her family and the HR director from the Southern Trust. So both parties agreed that there was no meeting of minds and agreed to me contacting the Ombudsman, Marie Anderson, which requesting her assistant to take the case forward. So I wrote and requested her intervention at the weekend. So could I suggest perhaps it would be helpful if the committee were to write to the department and make them aware that the Ombudsman has been involved in this case?
I don't think we need to do that, because I think when it goes to the Ombudsman, I mean, that's what we write to the Ombudsman regularly as MLAs, so I don't know if we need to write to the department to make them aware of that, but we can do it.
It's just it would be useful to seek their assistance providing all the information to ensure that
it's just we have a protocol agreed in this committee that we don't get involved in any work that MLAs are on, that they're doing, or constituency issues. That's our protocol.
But I didn't bring the issue to the
and my issue would have been to send this back. This is not an issue for the committee to look at. This is an issue for an individual MLA to take to the Ombudsman, because only they can do that.
Well, I point out I'm doing that. I didn't raise the issue with the committee.
No, well, that's fine. I mean, if members are in agreement, we can inform I have no issues informing the department, but it's not part of our protocol, just to point that out. But that's fine.
I agree, Chair, and I didn't bring the issue to the committee, but I'm responding when I see an issue which I'm dealing with personally as well.
Okay.
Sorry, Chair, could we just clarify then, is the committee agreeing that they're going to maintain the protocol, or are they deciding to contact the department?
Chair, I think we should maintain the protocol. The paper that I'm seeing here, it says that correspondence from David, it's been sent back to him to ask him to go to the local MLAs, and it's clear Ms. Dobson is dealing with the issue as well. I think that's important, but I think we need to be careful if we start responding to these on behalf of the committee. We're going to be, everybody's going to be writing in. But I appreciate your comment. You didn't raise it.
Yes, I'm happy, but I didn't raise it. But obviously, when you say a case that you're personally dealing with it, but I wouldn't have raised it with the committee. But just to be, so I'm happy to keep up that protocol, because, as Gary said, the Vice Chair, we could all bring so many cases that we're dealing with currently. So I'm happy to.
It's not going to add anything.
No, it's not.
In particular to her.
No, it's not going to add anything at all. So
no, I'm happy to uphold the protocol.
Okay then, members, if we move on then, can I draw members' attention to the tabled items of correspondence? On page 3 is a letter to the Health and Social Care Board, pressing on progress on paediatric community and hospital-based care and paediatric palliative end-of-life care strategies. These were consulted upon in 2014, and the previous committee was seeking information prior to dissolution. Are members content to forward this to the department with a request for information on progress? Okay.
Agreed, yeah.
Members, on page 6 of table papers is an email from Autism NI and the National Autistic Society NI. Are members content that the group be invited to stakeholder event?
Right.
Good stuff.
Agreed, yeah.
Okay, members.
Just in addition to that, I think it would be useful if we invite Pete to a stakeholder event as well. Is that,
Okay.
is that the one we're already arranged for at the ceremony?
Yeah. No, that's fine. Thank you, Daddy. Okay, move on to item number 10, which is any other business. Do members have any other business?
No.
Just wanted to ask, have we got a date for the stakeholder event?
We did have one, didn't we?
We've provisionally booked the 10th of November, but we'll confirm details and so on at your at your strategic planning meeting in September.
Thank you.
What is that stakeholder event, Elise?
That'll be an event where many of the groups that write in to come and speak to us. We hold a stakeholder event where we can invite several groups.
But it's not one common theme. There could be.
It could be a common theme, or it may not be, depending on the amount of groups at that stage that that want to talk with us.
Depends on your strategic planning decisions as well. If you've picked an area to do an inquiry or run a report, it may be that you wish to focus your first stakeholder event around that particular topic.
I'm sure we'll decide who we invite following the strategic planning day.
Well, some of them will invite, because we need to respond to them.
Understand that.
But the following ones after that, I think, will be more strategic in the planning. I think our first one, there have been so many groups have written in to come and speak to the committee or to give a witness session to the committee, and I think we need to deal with that in the first instance, and then maybe after that they'll become more topic focused in line with our strategic policies that we have. So if that's okay.
How many groups have we invited so far?
Have we a list yet?
We have a list compiled, but we haven't, obviously, because the details haven't been arranged, we haven't formally invited them yet. We've just alerted them that we anticipate that a stakeholder event will be arranged in the autumn. In fact, we think we said in November, and that we'll come back to some of the details once that's been agreed by the committee in September.
So, how many groups are we talking about so far?
I can find out if I can get back to you. I wouldn't have the
I
details.
think, Chair, it would be helpful that if all members could see the list.
Okay, well, it would have been through the correspondence that we've received, so if any member wants to look back on their correspondence and see what the action was, that will tell them also. So, I mean, any of the groups that will be coming, it will have come through, generally through committee and through correspondence, so, you know.
The list would include all stakeholders, the common stakeholders as well. We're not relying just on people who've contacted us. It would be the biggest range of stakeholders we can identify.
Well, could you get us a copy of that, just so we know?
We will be doing that for each September, yeah.
Absolutely. Okay, members, so move on to item number 11, which is date and time and place of next meeting. And the next meeting of this committee will take place at 10:30 on Thursday, the 15th of September, here in the Senate chamber. And I can also remind members of our strategic planning day, which will take place on Thursday, the 8th of September, in the Skinos Centre. And just to make members aware that details of all of those meetings will arrive in their emails nearer the time. So can I say I hope everyone has a good recess, and I'll see you in September. Thank you.
Thank you.
Programme sound. This is the Northern Ireland Assembly.